Good morning, everyone. It is my pleasure to welcome everyone to our Borneo Ophthalmic Update 2022. This year, our topic is focused on video retina and medical retina. We have an extensive panel of invited speakers and experts from all over the country to help us learn more about retinal diseases. I hope that you all enjoy the interesting sessions that have been planned for today and tomorrow. Please feel free to ask any questions to the panel of speakers. For tomorrow, we have some interesting sharing of video sessions planned for vitreoretinal surgery. I would like to express my sincere gratitude to all the committee members that have worked tirelessly to prepare these sessions, particularly Dr. Noor Hayati Abdullah and Dr. Mohammad Ishraq bin Mohammad Isa, and not least to all the participants for attending. Now, without further ado, I would like to hand over to our moderators for today, Dr. Yap Jin Yi and Dr. Anwar Zaki. Thank you.
Video. Boleh? Nampak ke? Start dah. You can hear me or not? No now.
Dengar apa?
Dengar saya cakap. Can ah? Clear right?
Yeah, clear.
A video can see me or not?
Here can see
Is the background is correct, right? Okay.
Okay. Okay, then I have to type something in the chat okay. All hosts and panelists only. I want to send to everyone. Hi. Testing.
Testing apa?
No, can you see my chat? Wait. Good morning. What's my name?
BOU 2022.
Okay. 那我来 draft 一个字。很多名字。怎么有我的讲话声音？为什么？
Yeah. Can you hear me?
Hey, morning, boss.
Yeah, can hear.
Can hear you
Okay,
loud and clear.
Alright. So
I'll see you later, boss.
I'll see you later.
Okay.
Okay, thanks.
Alright, thanks.
Okay, bye.
Check. Hello. Oh, can hear that. Sound check 1, 2, 3. Boleh ya? Boleh ya. Kau try. Rebel tu. Yeah. Can hear that. What you say? Loud, eh?
Hello.
Song can Sound check 1, 2, 3. No. Maybe it's the right side.
Hello. 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 Tapi nampak. Tapi nanti bisa dekat. Hello. Hello. test. 1, 2, 3. Very near. Mic check.
Mic check, mic check. Mic check, better.
Ada echo. Ada echo.
Echo.
Benda yang user computer.
Oh, echo. No. So it pause, it pause.
You're connected to all
Testing.
hotspot, you guys.
Tak ada.
Can hear the radio speaker.
Mic test. 1, 2, 3. Assalamualaikum and a very good morning to fellow consultants, specialists and participants. Thank you for joining us today in our very own Borneo Ophthalmology Update 2022, held here in Queen Elizabeth Hospital, Kota Kinabalu, Sabah. My name is Raden. I'm one of the medical officers in Ophthalmology department here, and I will be your host for today together with my fellow teammates and specialists as well. Before we begin, I would like to invite Dr. Sheena Mary Alexander, our consultant ophthalmologist and vitreous retina surgeon, as well as our head of department, to give you an opening and welcoming speech.
Good morning, everyone. It is my pleasure to welcome everyone to our Borneo Ophthalmic Update 2022. This year, our topic is focused on vitreous retina and medical retina. We have an extensive panel of invited speakers and experts from all over the country to help us learn more about retinal diseases. I hope that you all enjoy the interesting sessions that have been planned for today and tomorrow. Please feel free to ask any questions to the panel of speakers. For tomorrow, we have some interesting sharing of video sessions planned for vitreoretinal surgery. I would like to express my sincere gratitude to all the committee members that have worked tirelessly to prepare these sessions, particularly Dr. Nur Hayati Abdullah and Dr. Muhammad Israk bin Muhammad Isa, and not least to all the participants for attending. Now, without further ado, I would like to hand over to our moderators for today, Dr. Yap Jin Yi and Dr. Anwar Zaki. Thank you.
Thank you very much for your speech, Dr. Sheena. Good morning, dear participants. I'm Chan. I will be your co-host today for these 2 days alongside Dr. Raden. Dear participants, if you have anyone who wish to tune in but were unable to register in time, you can actually join via the YouTube link in the chat box at the site. Okay. To kickstart our BOU 2022, we will begin with the first session of the day, which is session 1 of Surgical Retina Symposium, featuring renowned VR surgeons all around Malaysia, namely Dr. Widat, Dr. Ang, and Dr. Zabri. Moderating this session will be our very own Dr. Yap Jin Yi. Dr. Yap is an ophthalmologist in Hospital Queen Elizabeth and also a lecturer at University Malaysia Sabah. Just a reminder, if you have any questions throughout the symposium, you can type your questions down in the chat box and our speakers will actually answer them during the Q&A session. Without further ado, I will pass the floor to Dr. Yap. Thank you.
Thank you, MC. Very good morning to our honorable speakers and participants. My name is Yap. Welcome everyone to Borneo Ophthalmology Update 2022 Virtual Symposium. This is a yearly event and we will be focusing on several topics on retina this year. We are honored to have a panel of distinguished retina consultants from all over Malaysia to speak to us today in a virtual symposium. We are also grateful to have more than 450 participants for joining us today. So without further ado, let's introduce our first speaker for today. Our first speaker today is Dr. Widat Muhammad Yusof. Dr. Widat is a vitreous retina consultant currently serving in Hospital Selayang. He graduated from University of Malaya in 1997 and obtained his Master of Ophthalmology from UKM in 2005. He then subspecialized in vitreous retina surgery in the University of Hong Kong and he completing his fellowship in 2011. Dr. Widat used to serve in Borneo as a vitreous retina consultant in Hospital Sarawak from 2011 to 2016. Today, Dr. Widat is talking to us on vitreous biopsy. Vitreous biopsy can be a lifesaver, especially when we are dealing with retina or vitreous diagnostic dilemma. Dr. Widat will present on when do we need to perform such procedure and how is it carried out. Let's welcome Dr. Widat.
Vitrectomy and internal surge. The complete vitrectomy might be therapeutic in the sense we aim to remove vitreous opacities, and debulking of vitreous cavity from any pathology in total. This in turn will result in reduced in antigen load, inflammatory mediators, or toxic elements. At the same time, you could check for any retinal breaks or tears that could be pre-existing or as a complication of the vitrectomy process, which could then be treated accordingly. The complete vitrectomy tool allows better evaluation of the posterior segment that would have been impossible in the presence of media opacity. So this table is showing the surgical burden in hospitals Layang over the past 20 years. We look at the burden of vitreous biopsy from 2000 to 2031. This is classified based on clinical diagnosis pre-operatively and not based on sample or yield or lab report. So vitreous biopsy on average constitute about 1.5% of annual vitreous surgical burden. The indication, the majority is because of suspicion of infective processes, which constitute about 2/3 of the burden. These are mainly the exogenous, including the post-operative endophthalmitis, the endogenous endophthalmitis. The inflammatory indication includes atypical, intermediate, posterior, or panuveitis, and as well as conditions those might mimic primary intraocular lymphoma and other masquerading syndromes. The indication for vitreous biopsy. In our setting, this is mainly to identify offending microorganism, though generally this would result in no growth. There are many reasons for this. For example, it could be due to inadequate sample, improper technique, or this eye might have been well treated with intravitreal antibiotic prior to sampling. Early vitrectomy is currently our main surgical intervention for post-operative endophthalmitis. However, intravitreal antibiotic is a must whenever we diagnose patient with endophthalmitis. Most uveitis is diagnosed based upon clinical manifestation tied with patient medical history, clinical cause, and therapeutic responses. Atypical presentation or disease that fails to respond to therapy in an expected manner, diagnostic vitrectomy could be helpful in discriminating between autoimmune disease, infections versus malignancy. The required volume needed by the lab for proper analysis varies according to tests required. These are some common tests requested. We need to check with the lab regarding the current availability and requirement for each test, the medium that is required, and the transfer time, and whether or not they need to be transported in cold chain. So generally about 1 ml of pure sample is required for each test. It is important to decide what tests is or are needed. More tests means more volume required. It is impossible to send everything, so we need to prioritize and send only what's required. Some of the tests has been done, cytology evaluation for cell morphology, in particular in primary intraocular lymphoma, the presence of large B-cell lymphoblasts and atypical lymphocyte with high nuclear or cytoplasmic ratio among small round lymphocytes. Usually, it might have a very high false negative rate due to small sample volume with low number of million cells, inadequate preparation of samples or carrying media, and previous administration of corticosteroid. Other tests will include PCR analysis, flow cytometry, and cytokine chemokines level. But we have to bear in mind some tests is not actually done in Malaysia. For vitreous sample, for example, flow cytometry is no longer done. Other infective tests is still being done in specific location. And the two that is done locally for each hospital, in each hospital, are just cultures and sensitivity and cytology. And for cytokine chemokines, I think hospital only do interleukin 6 and not interleukin 10. The interleukin 10 interleukin 6 ratio more than 1 is suggestive of malignancy. So some of the challenges in acquiring vitreous samples. So we know the vitreous volume is approximately 4 mils. The ability to obtain 1 to 1.5 mils of undiluted sample is luxurious. Diluted sample might be useful, but need to discuss with pathologists about any concern using diluted samples. So we need to ensure adequate volume, decide what tests needed. Sample viability and integrity will depend on some factors, namely the proper transit time and condition, which includes the transporting media and the temperature during the transit. For cultures and sensitivity, it is best to inoculate directly in the culture plates and the slides so that sample could be safe for other purposes. Some papers describe sending the entire sample in vitrectomy cassette to be processed. Depends on local pathologist acceptance. It might have greater yield. For example, in primary intraocular lymphoma, it's suspected. Core samples is less cellular compared to the cortical samples. So if we could actually harvest the entire vitreous and send to the pathology, the yield might be more. Vitreous biopsy technique. This is done in controlled conditions. So generally, we use high vacuum. This is done manually by the end assistant, who will directly aspirate the sample into a syringe collector. Alternatively, we may acquire the sample collected in the tubing. We use the vacuum from the machine. The problem with this is samples tend to collect in segments in the tubing and difficult to collect fully by reflux or aspiration. Some is wasted as they will remain in the tubing wall. But this is an option if an assistant is unfamiliar with the procedure. We use a low cut rate to maximize the chunk of tissue in each bite and avoid tissue damage or degradation due to high cutting speed. The infusion typically is put in off or clamp position after priming with BSS. The IOP is maintained by external compression using cotton bud on the sclera during sampling. Any gauge could be used for sampling. Alternatively, the machine could be primed using air instead of BSS. Both machine, Constellation and Stellaris, can do this. Air infusion is turned on during sampling at standard 40 mm mercury. Sampling done as above but under air. IOP is maintained by air infusion. 2 to 3 mils of pure sample could be obtained this way. Some cautions is that in phakic patient, gas cataract may develop if the procedure takes too long. So this is what the general setup usually is. In B, the vacuum tubing is disconnected from the cutter. The cutter is connected directly to a syringe 3 or 5 mils to collect the sample. In A, you can see the surgeon depress the pedal to cut the vitreous. At the same time, an assistant aspirates sample into the syringe. Alternatively, we may use a 3-way connector as in D. So one of the disadvantages of sampling in the conventional manner is that the amount of volume that we get is only about 1.5 cc's of undiluted sample. So to get a larger volume, the alternative methods could be used, whereby we do sampling under air. So the disadvantage is that the larger volume of sample could be obtained up to 3 cc's. And we could focus in the area of cortical vitreous where we think the pathology could concentrate. So in this method, we prime the cassette under air, and air infusion at 40 millimeter mercury is used throughout the procedure, and with a cut rate of 100 cut per minute. Aspiration of sample is done in the usual manner by an assistant. The sampling is done until the desired volume is achieved without worrying the eyeball collapsing, because it is maintained by the infusion of air. So once nearly enough sample harvested, we switch to BSS. It will take some time for the tubing to be filled with BSS, and BSS infusion begins. Gas cataract may hamper subsequent completion of PPV in phakic patients, so we have to be mindful not to take too long to do this procedure. One important tip is to ensure the cutter pot is facing up all the time to avoid inadvertent injury to the underlying retina. So the usual conventional way of vitreous sampling that we normally do, the limitation is that the amount of vitreous that we get usually in the region of 1 to 1.5 cc, that might not be enough for the test that we needed. So one alternative way is to do the vitreous sampling under air. In this process, priming of the machine is done dry or under air. And the process of sampling is similar in a conventional way, whereby assistant will aspirate directly from the vitreous cutter. And the infusion rate of air is put at the normal standard 40 millimeter mercury and a cut rate of 500 cut per minute. So the other advantage of doing it under air is that the location of cortical vitreous that might have the most concentration of cells could be seen, and we can actually sample directly at that site. So because of the potential of cataract formation due to the presence of gas in the vitreous cavity, the procedure must be kept to the minimum duration. So we can see in the video that the movement of vitreous during sampling is clearly seen. However, to avoid inadvertent injury to the retina, we must ensure that the pot is facing up all the time. There need to be some synchrony between the surgeon cutting and the aspiration by the assistant, and you can see in the video that gas cataract has actually formed in this patient. The other thing we need to remember is that once we want to change back into BSS, there'll be a delay before the infusion start to pour in because the BSS need to fill the tubing first. Sampling under air is an alternative method to the conventional sampling technique. It allows us to have a bigger volume of undiluted sample to be sent for testing. With that, thank you and happy sampling.
Thank you, Dr. Vidat, for the wonderful presentation. A reminder to all the participants, if you have any questions, you can type in the Q&A box and we will discuss the questions at the end of this session. Okay, let's welcome our next speaker. Our next speaker is Dr. Ang Yi Ling. Dr. Ang is currently the head of the department as well as the Vitreous Retina consultant in Hospital Pulau Pinang. She graduated from Kasturba Medical College, Manipal in 1996 and obtained her Master of Ophthalmology from University Malaya in 2006. She then completed her Vitreous Retina Fellowship in Sydney Eye Hospital in 2013. Dr. Ang's presentation today is on intraocular foreign body. Intraocular foreign body is not an uncommon condition when dealing with our ocular trauma cases during our daily on-call. Dr. Ang will be guiding us on practical approaches to intraocular foreign body through her presentation. Let's welcome Dr. Ang.
Morning, everyone. First of all, I would like to thank the organizing committee for inviting me to speak in this Borneo Ophthalmology Updates, the Retina Series 2022. The task given to me this morning is to deliver the topic on the approach of intraocular foreign bodies. As we know, open globe injuries with intraocular foreign bodies are critical ophthalmic emergencies. Hence, they require urgent diagnosis and prompt treatment so as to preserve the globe and also prevent blindness. Many studies have shown that these open globe injuries can cause severe visual loss. We have done a retrospective studies in Penang Hospital in year 2014. Out of the 87 patients with open globe injuries, 8% of them present with intraocular foreign body. Our studies is consistent with the studies done by Kuhn et al. In year 2000. Majority of our patients are male, their age range between 21 to 40 years old with mean age of 29 years old. The most common location of the injury is their workplace. As you can see, the age range is at the most productive age group. This can indirectly burden their family and also the economy of the country. Let us see some case that present to the Penang Hospital. This is a 32-year-old Bangladeshi male who came with a complaint of injury to his left eye while working. He was hammering a metal object with the metal chisels at that time. He claims that he's not wearing any protective eye gear. At that time, he complained of decreased visual acuity, pain, and redness. This is the eye when we see him. This is a 23 years old Bangladeshi construction worker. He came with a complaint of progressive blurring of vision of his left eye over the past 1 month. He gave history of dust entering his eye while working about a month ago. At that time, he only experienced mild pain, tearing, and redness, and he denies any blurring of vision. And he also claims that he's not wearing any protective eye gear. At the same day, he has sought a GP treatment. He was told everything is normal and he was just given eye lubricants. This is his eye on presentation. So, what to do next? it is mandatory to rule out intraocular foreign body in all open globe injuries. So the objective of today's presentation is to know how to assess the patient with intraocular foreign bodies, how to locate and confirm the diagnosis, what are their indication of removal, what are the timing of removal, and the surgical approach. In all open globe injuries, a detailed thorough history is very important. This can help us to ascertain the type and material of the foreign bodies, and it can also help us to suspect and diagnose intraocular foreign bodies, even though in a very severely traumatized eye, when the examination of the eye is limited because of corneal haziness, hyphema, cataract, vitreous hemorrhage, or retinal detachment. History should include the mechanisms and the circumstances of injury. Example, is it due to assault? Is it due to motor vehicle accidents? We also need to know the time of injuries to the time of the patient present to us. What is their ocular and visual symptoms? Do they have any prior treatments? And is it a work-related incidents? All these documentations are very, very important, as we know that the medical legal cases are increasing nowadays. Another ocular history that need to be recorded is the use of protective eye gear, any loss of consciousness, any concurrent bodily injuries associated with the trauma. Does the patient have history of any ocular surgeries? All these are important in the planning of the management of the patient. Ocular examination should include a proper documentation of their visual acuities. We should check the affected eye for a relative afferent pupillary defect, but if the pupil is obscured by the injuries, we should check a reverse afferent pupillary defect. Intraocular pressure is usually contraindicated because of the open globe injuries, and we should look for any associated injuries like orbital fractures, retrobulbar hemorrhage, any laceration wounds, and any visible foreign bodies. If the patient is stable, we should always examine them under the slit lamp. We should look for any puncture or laceration wound, and CIDR tests can be done to identify any leaking wounds, but always bear in mind that there's something called a cell seal wound, so we should examine the eye properly. And we can examine the anterior chamber for any signs of severe inflammations, any signs of endophthalmitis, and we can look for any capsule rupture by looking at any lens material in the anterior chamber, and look at the pupil for any change in their size and shape. Iris examination should be done prior to dilatation. We should examine for transillumination, which may suggest us a potential intraocular foreign bodies. Gonioscopy and scleral depression are generally not recommended because it can further extrude the eye content. If we examine the eye, we saw a uveal tissue incarceration in the laceration wound. Generally, the pupil shouldn't be dilated. And we should look at the lens for any capsule breach, and we can look for the position of the lens and also the stability of the lens. And the lens clarity is also depends on the location of impact, the size of intraocular foreign bodies, and also the time of presentation. If dilatation of the fundus is possible, we should look for any intraocular foreign bodies, and we can look for any associated injuries like the presence of any vitreous hemorrhage, the presence of any retinal detachment, tears or dialysis or commotion. Look at the choroids for any ruptured, any choroidal detachment, any choroidal hemorrhage. If possible, sometimes we can see the posterior exit wound, and also there's something called a scleropataria. Studies has found that the common entry site of intraocular foreign bodies is through the cornea. It is about 65%, and 61% of the intraocular foreign bodies lodged within the vitreous cavity. Clinical examination alone cannot identify all foreign bodies. Ocular imaging plays an important role to confirm and to rule out intraocular foreign bodies. Even though we can identify the intraocular foreign bodies during fundus examination or during slit lamp examination, it is important to do ocular imaging so as to rule out other foreign bodies or any presence of multiple foreign bodies. And ocular imaging also can help us to accurately localize the intraocular foreign bodies to ease us during a surgical removal. What are the ocular modalities that we can do? Commonly done is plain X-rays. CT scans is the utmost important, then followed by ultrasound, and MRI can be done in certain cases. Plain X-ray is still a useful screening tool to identify a radio-opaque intraocular foreign bodies. So when we order a plain X-rays, we should write clearly in the forms that we want a Waters view, Caldwell's view, and also a lateral view of the orbit. CT scan remains the mainstay and also the most reliable methods in identifying intraocular foreign bodies. It is widely available, it is fast and effective. By doing the CT scan, we can also look at the globe contour. Is there any site of posterior ruptures? We can also look for any orbital fractures, any hemorrhage and retrobulbar hemorrhage, and also we can look for any associated cranial injuries like a subarachnoid hemorrhage. So when we order a CT scan, we should write clearly we need a thin 1 mm cuts so as not to miss a small intraocular foreign bodies, and we should order that we want a coronal view, axial view, and also sagittal view. Non-metallic intraocular foreign bodies like wood are usually hypodense on CT scan, and it can be easily mistaken for air or fat. But keep in mind, if there's any presence of linear appearing air in the CT scan, we should be suspicious of non-metallic or wood intraocular foreign bodies. In CT scan, they use some measuring units called as Hornfield units. This can help us in identify the different composition of the intraocular foreign bodies as shown in this chart below. B-scan ultrasound is not routinely done because of the presence of open globe injuries. By doing a B-scan, it can further expose the intraocular contents. But B-scan is a useful tool in localizing and identifying a radiolucent intraocular foreign bodies that are not seen in CT scans. It can also used to locate a very small non-metallic foreign bodies which is at the angle, ciliary bodies, ciliary process, and also at the retrolental space. Even though MRI is the only imaging that is capable of detecting small plastic or wood intraocular foreign bodies, it should not be the first ocular imaging to be done. It should be done only when metallic intraocular foreign bodies is being ruled out, because its strong magnetic force can produce movement of the metallic intraocular foreign bodies, causes a further ocular damage. Should all intraocular foreign bodies be removed? The answer is yes, but in special circumstances where the patient comes with a very good visual acuities, there's no evidence of endophthalmitis, and we think that the removal can cause more harm and damage to the eyes. In this situation, we can wait and watch and follow up the patient regularly. During the follow-up, check their visual acuities, examine the patient under slit lamps for any toxicity, and we can do a serial electroretinograms. So, what are the indications of removal? All metallic objects ideally should be removed because there is evidence documented that they cause toxicity to the intraocular tissues. Like in iron, they cause siderosis, and copper cause chalosis. And any intraocular foreign bodies which are contaminated with vegetable matters, they should be removed because there's an increasing rate of endophthalmitis. So these are some flowchart showing the toxic and inert foreign bodies. The main goal of management, of course, is to achieve the best visual outcome for the patient, to identify and closure of the wound, to reconstruct the eye, and lastly, to remove the intraocular foreign body. When we first see the patient, remember to protect the globe by using an eye shield to prevent further extrusion of the eye contents. We should clean up the surrounding areas, start the patient on broad-spectrum antibiotics while waiting for surgery, and don't forget about tetanus toxoid. Consent and counseling of the patient is very important. They should be explained that they may need multiple and stage surgeries to address all the sequelae of the ocular trauma. They should be explained about the visual prognosis and also the unpredictable final visual outcome due to the potential visual threatening complications like retina detachment, endophthalmitis, and lastly, blindness should be included in the consent. Actually, blindness should be included in the consent in all ophthalmic surgery. What are the factors that affect the final visual outcomes? Many studies have shown that a better presenting visual acuity are more likely to have a better visual outcomes, and anterior chamber intraocular foreign bodies are associated with a better visual outcomes compared to the posterior segment intraocular foreign bodies. And the final visual outcome also depends on the size and location of the intraocular foreign body's entry wound. Is there any presence of RAPDs, any associated ocular injuries like intraocular hemorrhage, retina detachment, or any presence of endophthalmitis at the time of presentation? Many controversies has been debated over years in the management of intraocular foreign bodies. These include the timing of removal of intraocular foreign bodies, the method and route of removal, any need of prophylactic buccal, the benefit and the need of prophylactic antibiotics and also their route of administrations, any placement of IOL in the acute traumatic setting. When is the best time to remove an intraocular foreign bodies? We should remove it immediately or we can delay the removal. Initially, it is thought that an acute intraocular foreign body should be removed as soon as possible because the delay of removal can cause a higher rate of endophthalmitis and also can increase the rate of PVR. But in a study by Cutler and colleagues from Walter Army Center, they studied about the US Army who had combat ocular trauma in the Iraqi-Afghan Freedom War. It shows that a delayed intraocular foreign body removal with a combination of systemic and topical antibiotics coverage has the similar outcomes with prompt removal, and the mean time of removal of IOFB is 21 days. It is postulated that the IOFB would have been potentially steriled by the heat from the exploding ordnance. Vitreous et al. Also shows that there is no increase in endophthalmitis or PVR formation with the delay of removal of intraocular foreign bodies. These studies have shown that the delayed approach can possibly reduce the complexity of the surgical procedures. This is because of the presence of PVD. There's a liquefaction of the traumatic blood clots. The risk of bleeding from the retina and choroids is much lesser. The risk of PVR formation from the wound edges is highly reduced. And by this time, the traumatic hyphema or the fibrinous aqueous would have resolved and the corneal edema would have been clearer. Pars-plana vitrectomy is the routine technique to remove the intraocular foreign bodies. Besides that, it provides the best access for repairing concurrent injuries like vitreous hemorrhage, retinal tears, retinal detachment, and also lenticular injuries. Studies has found that the large volume irrigation of the posterior segment would have likely reduced the risk of post-op endophthalmitis. Before the era of routine pars-plana vitrectomy, external electromagnets are the primary means of removing the metallic intraocular foreign bodies. The devices are large and cumbersome. The results are unpredictable and often cause serious iatrogenic injuries to the globe. And the rate of developing of PVR and its associated complications is very high. Before removing the vitreous, ideally we should take an undiluted samples of the vitreous for gram stains and culture. All the media opacities should be removed so as not to obstruct our view during vitrectomy. A 3-port pars-plana vitrectomy can be done via a 23 or a 25 gauge cannula. First, we need to identify whether there's any PVDs. If there's no PVD, we should induce posterior vitreous detachment. All the vitreous adhered to the IOFB and all the scar tissue should be removed until the IOFB is free. Then the IOFB can be removed either with an internal magnet or forceps depending on the composition of the IOFB. Small metallic foreign bodies less than 3 mm can be removed with intraocular magnet via a sclerostomy or a corneal incision, while a large metallic or non-metallic intraocular foreign bodies can be removed with an intraocular body grasping forceps. This is a video showing how we remove the intraocular foreign body. After vitrectomy, we do some indentation to look for any tears. And the intraocular foreign body is removed with a intraocular body magnet and passed to the grasping forceps. And it is removed via an enlarged sclerostomy. The claw-shaped IOFB removal forceps is a new specialized forceps which is suitable to be used for a larger non-magnetic intraocular foreign bodies because it can strongly grip the intraocular foreign bodies in the mid-vitreous, while the other hand can create a limbal or a sclerostomy. Another technique which can be used to remove a larger non-metallic intraocular foreign body is called as cross-knot technique. They use 270 Vicreous suture which are placed perpendicular to each other, and the suture are tied with surgical knots. After that, the 4 ends are glued together with viscoelastic and it is introduced into a 20 or 23 gauge needle. Because of the soft suture nature, it enables it to shape according to the intraocular foreign bodies, and it also provides a multi-plane grafts. This diagram illustrates how the intraocular foreign bodies is removed through a cross-knot technique. So after forming the cross-knot, it is inserted either through a limbal of pars-plana wound, and the 4 suture is placed approximately around the intraocular foreign body, and the foreign body is adjusted inside the basket to make the maximum cross-section smallest to the exit plane, because this can make the exit wound as small as possible. So After removing the intraocular foreign body, we should do a 360-degree indentation to look for any retinal breaks. Then we can do a fluid air exchange, address any breaks with endolaser. We can consider the use of silicone oil or gas endotamponade, especially when there is a retinal detachment. And intravitreal antibiotics can be injected if there's a patient is at risk of endophthalmitis, and all the sclerostomy should be closed. Post-operatively, we should give the patient aggressive antibiotics both topically and systemically. We should go in the operation theatre early for repeat of vitrectomy and intravitreal antibiotics if there's endophthalmitis. And we should follow up the patient closely for any retinal detachment, because this is a common cause of poor functional outcome. The rate of retinal detachment is between 6 to 40%, and we should follow up the patient for any development of cataracts. During the follow-up, if we see any unexplained post-op granulomatous inflammation, we should think of sympathetic ophthalmia, although this condition is rare. It occurs in only 0.28 to 1.9% of patients. Let us look back on the case that I presented earlier. Both the patients are in their productive age group, both didn't wear any protective eye gear, and all the injuries occur at their workplace. The first case presented immediately with the vision of only perception of light, and the intraocular foreign bodies are removed via an external magnet, and then the wound is sutured. The final visual outcome is only perception to light. I am lucky enough to observe the removal by external magnet during my master's. And the second case is presented after 1 month, which is missed by the general practitioners, and its vision at presentation to us is only counting finger due to the cataract. The intraocular foreign body is removed via a pars-plana vitrectomy. We use an intraocular magnet and also an intraocular forceps, and have his final visual outcome is 6.9. With the case 2, it is proof again that a delayed removal of intraocular foreign body also has a good visual outcome. These are some of the take-home message. Always remember, in all open globe injury, we should rule out intraocular foreign body unless proven otherwise. It is a big no to do a MRI imaging unless a magnetic intraocular foreign bodies has been ruled out. And we should recognize subtle clinical signs so as not to miss any intraocular foreign bodies. And we should immediately close the wound and give the patient intravitreal antibiotics and also a systemic antibiotics. And there's a role of delayed cataract and intraocular foreign body removal. And we should counsel the patient to wear protective eye gear, because this simple eye gear can act as a primary barrier against such. These are the flowchart that can help us in the management of intraocular foreign bodies. And these are my references. With that, I thank you.
Okay, thank you, Dr. Ang, for the wonderful presentations. So to the participants, if you have any questions, please type in the Q&A box or chat box. We'll reply you or we'll answer you later on during the Q&A session. Okay, so let's welcome our next speaker. Our next speaker is Dr. Zabri bin Kamaruddin. Dr. Zabri is a vitreous retina consultant currently serving in Hospital Selayang. He did his undergrad in University Kebangsaan Malaysia in 1995 and obtained his Master of Ophthalmology in 2002. And subsequently, he completed his Vitreous Retina Fellowship in 2010. Dr. Zabri is also currently the National Head of Vitreous Retina Service and Training. And Dr. Zabri used to serve in Borneo as well. He was an ophthalmologist in Hospital Umum Sarawak from 2003 to 2005. Today, Dr. Zabri will be talking to us on advanced diabetic eye disease. As we are all well versed in diabetic retinopathy becoming more common in Malaysia, it is undeniable that the severity is raising a major concern as well. Advanced diabetic eye disease is becoming more and more common among our patients. On that note, let's welcome Dr. Zabri, who will be presenting on the tips and tricks in the surgical interventions of ADED. Let's welcome Dr. Zabri.
Assalamualaikum and good day. Thank you to the organizing committee for inviting me to give a talk regarding tips and tricks in diabetic vitrectomy. Despite treatment of earlier stages of diabetic retinopathy with either medical therapy, which include intravitreal injection of antivascular endothelin growth factor (anti-VEGF), intravitreal injection of steroid, and retinal laser photocoagulation, several eye would progress to require surgical treatment. Diabetic vitrectomy is considered to be among the difficult case in vitreoretinal service, and it is the last hand-on in surgical vitrectomy training due to its difficulty. Managing diabetic vitrectomy, first of all, you must know your patient well. Pre-op counseling is very important to explain the prognosis of the disease, and we want to know the expectation of the patient, because sometimes diabetic vitrectomy is an unpredictable condition. The systemic condition is very crucial, especially the end-stage renal failure, whereby hyperuremic will cause intraoperative bleeding. Social support, we must consider it for post-op care, and we must review the stage of the diabetic eye disease. Otherwise, it will be a lot of surprise intraoperatively. Laser PRP is first thing that I ask all to my patient, because it really changed the scenario in the operating theatre. We also must know the basic concept of the vitrectomy cutter, whereby it's a cutter in the gluting types, where it used to aspirate the vitreous into the cutter and cut and aspirate it. It's not meant for membrane actually, and then that's why we must stay near to the edge of the membrane to have efficient cutting. That's why the lift and shift technique is come all about. We must very familiar with the vacuum system, otherwise we're cutting the membrane as well as the retina. And I use the 90 and as well as the 120D lens in my diabetic vitrectomy cases. The end point of diabetic vitrectomy is to remove all the posterior hyaloid, because the posterior hyaloid might contract and cause more problem post-operatively. We try to avoid bleeding pre-operatively, probably with anti-VEGF, intraoperatively with a very careful not to cut the vessel, and post-operatively probably heparin-free hemodialysis. We must avoid any retina break, because it's not easy to flatten the chronic retinal tractional RD. And both segmentation and block dissection technique I use to do diabetic vitrectomy case, and start with relief of anterior posterior traction, relief of tangential traction, and do the lift and shift technique for diabetic RD. I prefer general anesthesia in a difficult case and a young patient. I do 23 gauge, 25 gauge, and 27 gauge. I prefer 25 gauge. 27 gauge is quite good, it's small, it's easy to go under the membrane. However, it's fragile and the opening is so small that it's very difficult to catch sometimes a very thick membrane. The 3 or 4 port is for bimanual technique. I always start with 360-degree vitreous clearance under 120D, and I will confirm with the vitreous skirt. I will show you in the video in short while. And I shorten the skirt, the vitreous skirt, under 90D length, And after that, next stage is to look for the window for the posterior hyaloid and divide and conquer segmentation around the packs. I changed to low cutting rate for chipping vitrectomy for the efficient cutting and safety vitrectomy. And then complete laser photocoagulation, tamponade if necessary. I try to maintain the moderate intraocular pressure and surgical time to have a good mean ocular perfusion pressure. This case illustrates the diabetic membrane, which is very adhere to the retina around the optic disc and the arcade. Is a common presentation of a diabetic membrane. I start the vitrectomy with to remove anterior posterior traction by clearing all the vitreous 360. If there is a lot of scar, it's easier for me to induce the PV if there is none. It is a learn to see the vitrectomy whereby I stay at the face of the membrane facing the port to the sea of the retina and cut the remaining remaining vitreous skirt until at the edge to the membrane. I changed to 90D to have a better depth perception, and with a good depth perception, I'll cut some more up to really edge of the diabetic membrane with learn to see technique. Or rather, I learn to see technique. Stay in the face of the membrane facing outward. Then next stage, start to looking to the window to the posterior hyaloid. Usually start from the most posterior to the anterior, but usually I end up in the around the optic disc because of the counteraction from optic disc. Next stage is to go to under the subhyaloid space. As I told you before, actually end up at the area of the optic disc, cut into the island into a small tiny island as a divide and conquer procedure. It's like a hole and cut. This is the time I use a low cutting rate, chipping vitrectomy, what we call it chipping vitrectomy in our center, and start from there. We know we are at the right plane, and sometimes I use the light pipe to help to separate the membrane. And use the chipping vitrectomy technique again to have an efficient cutting and a very safe vitrectomy to cut the membrane. I usually go to the tip of the membrane last because usually is where the adhesion is the most tight. And try to cut around it rather than under it. This hold and cut, usually I hold with the vacuum on, and with the vacuum on I turn on the cutting mode and go into the next island with the same technique. I try to have an opening in the tunnel and cut through it. You can see here it's very obvious it is a attach and cut with the chip vitrectomy because the membrane will come to you. If you can see here, there is not much bleeding that I need to increase the intraocular pressure. We must consider the mean ocular perfusion pressure during our surgery. It's almost finished, and after this it's laser and cataract. Not much bleeding there. I think with that I thank you.
Okay, thank you very much to Dr. Zabri for the presentation. We are coming to our Q&A sessions. I would like to welcome our speakers, Dr. Vidat, Dr. Ang, and Dr. Zabri, to join our Q&A session today. There are a few questions were mentioned in the chat box, and all the questions were towards Dr. Ang, and it was answered by Dr. Ang already. Participants can view the chat box to get a question and also the answer. Besides, we also have other few questions for our speakers. First questions is for Dr. Vidat. Are there any circumstances that would require a repeat vitreous biopsy, and how soon we can repeat the biopsy? Dr. Vidat?
Hey, good morning, everyone. So far we have not. Can anyone hear me?
Yes, Dr. Vidat, we can hear you.
So far we have not encountered many of those cases that require repeat biopsy. I mean, if we feel that we have missed something during the first biopsy and everything, the sampling not enough or something like that, probably there's a role of repeating biopsy. But be mindful that most probably vitreous would have been cleared up mostly in the first vitrectomy. So the only thing you might just do with vitreous step would be probably be just enough rather than repeating a biopsy.
I see. All right, thank you, Dr. Vidat. Another question for Dr. Vidat as well. Is there any conditions where the vitreous stepping is more preferred than vitreous biopsy?
Well, I suppose the answer is that to that question, if you don't have vitrectomy service or vitrectomy service in your area, because we know that the amount that you get with the just stepping is not going to be enough unless you're just doing something like PCR for the viral, the viral PCR, things like that. But for cells, probably it won't be enough.
I see. Thank you, Dr. Vidat. Okay, so next question is for Dr. Ang. Okay, one participant is interested in Dr. Ang's study. Dr. Ang, based on the study you mentioned just now, what will be the commonest mode of injury in the intraocular foreign body?
Oh, okay. Thank you for the question. Actually, we done a study. The most common mode is still at the working place. So actually we found that a lot of them is like a foreigner. Okay, as you can see, both of my cases is also a foreigner. And also the people who like do grass mowing. Okay, they do the grass thing. Sometimes that's why if you see people cut grass, please stay far, far away.
Yeah, exactly. Yes. Thank you, Dr. Ang. So yeah, another question is, in the case of intraocular thrombotic with traumatic cataract, should we leave the eye phakic or should we put in the lens during the intraocular thrombotic removal?
That is a very good question. So if let's say there's an intraocular foreign body, you see as the case that presented with a delay a month, he came a month ago, a month after that. So basically he developed cataract. So last time when I was in training, there's one specialist like presented a case and the conclusion is all cataract need to be removed on the same setting. Okay, but for me, I think it's wrong. We can actually leave the cataract. We can remove it later if there is no problem. As you can see, many intraocular thrombotic is missed. So, but there's expulsion of lens material, there's severely Jacksonian sign ruptured. Definitely, it is mandatory to remove. So for me, my practice, I basically leave them aphakic if they come with intraocular foreign body, because a fear of another foreign body like IOL, we consider this as a foreign body. I'm fear of endophthalmitis. So we can always go for, it's safe to go for a secondary IOL, but the problem is we need another surgery. Yeah, my practice, I'll do secondary.
I see. Thank you, Dr. Ang.
Yep.
And there's another question for Dr. Ang again. So Dr. Ang was mentioned about the heat can sterilize the intraocular foreign body. So how does the heat actually help to sterilize the foreign body?
I basically I think every heat like they can actually kill the, assumedly they can kill the organisms. So as proven in the combat study, ocular trauma study. So they have proven it that delay removal is actually a better choice. Yeah, unless it's vegetative. Okay, you know that it's stone, this type of foreign body, then we shouldn't leave it. We should remove it because the rate of endophthalmitis is very, very high.
Okay. All right. Thank you, Dr. Ang.
Welcome.
So, all right. Next question is for Dr. Zabri. Hi, Dr. Zabri. How would you proceed in the case of advanced diabetic eye disease with rubeosis and high intraocular pressure with no view of laser?
Patient with rubeosis iridis, usually we don't do surgery on them because especially with high IOP, once you introduce anything to the eye, the pressure will drop and then there is bleeding inside the eye. Rubeosis iridis without laser considered an endgame patient. To me, it's only consider conservative therapy only. When I was in postgraduate day, I assume rubeosis iridis without laser, it's not to be treated, it's to be prevented. We should prevent rubeosis iridis rather than to treat. It's an in-game situation to me. Thank you very much.
I see. Thank you, Dr. Zabri. One more question for you, Dr. Zabri. When do you decide for conservative management in ADED?
I put it is inoperable condition where there is very extensive TRD and usually with funnel RD. Usually, and then I also follow the vision. I start my vision at PL. Hand movement is depend on the intraocular finding, but PL usually won't do good. If patient present, young patient present PL both eye, the previous preceding case, I try once or two, but it won't come good. Although surgery is successful, they won't get any vision. So I stop at PL won't do. And the hand movement depend on the fundus finding.
I see. Thank you. Okay, Dr. Zabri. One more question for you, Dr. Zabri. in the event of like post-vitrectomy and there's recurrence of vitreous hemorrhage, when will you go in again for the next surgery?
Usually, if there is no persistent bleeding, then we stop at 1 month. And then usually what I do is I wait until 1 month. And if 1 month still residual bleeding there, I suggest for anti-VEGF injection. And I wait another 1 month. If not, I will go in for washout. And the usually outcome is we don't clear the retrolental vitreous. It's always like that. If you don't clear the retrolental vitreous, they will come up with a vitreous hemorrhage. So usually, if the simple bleeding after 1 month will resolve, and sometimes one injection also will resolve. So I wait until around 2 months to go in again.
I see. Okay, then thank you, Dr. Zabir. I think to the participants, do you all have any other questions want to ask our panelists? So far, we don't see any other questions. Among the panelists, do you have any questions for each other? Okay, if there are none after other questions, we shall end our Q&A sessions. Thank you so much for all the panelists, Dr. Vidat, Dr. Ang, and Dr. Zabi. We will continue with our next session. Thank you so much. I'll pass the floor back to the MC.
Thank you to all speakers and Dr. Yap for moderating the Q&A session just now. Now I would like to pass the floor to Dr. Anwar Zaki, one of our Queen Elizabeth Hospital and Likas Hospital ophthalmologists, to moderate the next session. Hello everyone, I'm sorry for the short delay. We'll be having a 10-minute short break. We'll be resume back around in 10 minutes time. Thank you for joining us again. I will now pass the floor to Dr. Anwar Zaki, our Queen Elizabeth Hospital and Vikas Hospital ophthalmologist, to moderate the next session. The floor is yours, Dr. Anwar.
Thank you to the MC, Dr. Raden. Next, I would like to present the next speaker to deliver on the highlight lecture. Dr. Fariza is the National Head of Ophthalmology Services in Malaysia. She is also the Head of Department of the Shah Alam Hospital, as well as Head of Unit for Retina and Uveitis Services. She obtained the Master of Surgery in Ophthalmology from UKM in 1998, subsequently completed her fellowship in Medical Retina and Uveitis Disease at the Moorfields Eye Hospital, University College of London in 2003. Dr. Fariza plays a key role in establishing formal training structure in medical retina and uveitis and transformed the unit into the largest medical retina center in Malaysia. We would like to invite Dr. Fariza to present on the updated guideline for diabetic macular edema from the MOH consensus guideline. Please welcome Dr. Fariza.
Thank you, Dr. Anwar, for the very kind introduction. And thank you for the organizing committee for this invitation. So can you all see the slides? All right, shouldn't be a problem, right? I'm going to talk about the diabetic macular edema. The Ministry of Health, Ministry of Health consensus that was published last year, 2021. And we will talk about why this actually consensus has been done in Malaysia for our reference, especially among the Ministry of Health doctors. So this is actually my disclosure. I have nothing to disclose in regards to this presentation. So diabetes mellitus is actually a very well-known global emergency. If you can see the world map there, showing the increasing projection of prevalence of diabetes worldwide. So it was projected that 425 million of world population actually affected with diabetes mellitus, and by 2045, 629 million of population has been projected to actually suffering from this. And more than 130 million people suffer from some sort of eye damage in if they are having diabetes. So they put there the terms that more than 1 in 3 living with diabetes will develop some sort of diabetic retinopathy. So what is the diabetes status in Malaysia? I think this slide is a very famous slide. We have been showing this to show the prevalence of diabetes is increasing from the National Health Morbidity Survey done in 2011. It was 11.2, then increased to 13.4 in 2015. And the latest survey 2019 showed a prevalence of 18.3. And what worries is about the rate of unknown diabetes. That means they noted to have high blood glucose during the survey, but they are not known to have diabetes, about 9% of the study population. And 1 in 5 of our adult in Malaysia actually suffering from diabetes mellitus, which projects about 3.9 million of people aged 18 years and above suffering from this condition. So diabetic macular edema, the prevalence of this condition range from 11% in Europe to about 7.5% in African countries, and more than 21 million people are affected worldwide with this condition. And it was estimated that 20% of people living with type 1 diabetes and 25% those with type 2 diabetes actually expected to develop some degree of diabetic macular edema. So this condition, DME, has emerged as the leading cause of visual impairment in person with diabetes. So diabetic patient, actually, their life can be very complex because they can develop all sorts of comorbidities in relation to the diabetes. But the common micro and macrovascular comorbidities are diabetic retinopathy, which is postulated to be about 28.5% in patient aged more than 40 years old. And from this 28.5%, 13% of this population actually will develop diabetic macular edema. So they are at risk about 8.5 to develop stroke in patient aged more than 35 years, 20% to develop any form of cardiovascular disease, also in the patient aged more than 35. 33% can develop diabetic retinopathy in overall diabetic population, and about 70% of diabetic population will have some sort of diabetic retinopathy as their comorbidity in relation to diabetes. So why are we very concerned about this diabetic retinopathy or diabetic maculopathy? This is basically because of this condition give a significant problem to the patient in view of as one of the leading cause of blindness. It eventually taken away patient independence, and they becomes heavily reliant on family, friends for practical support, which leading them to feel disempowered or sometimes frustration and depression. Okay, they have feeling lack of confidence, especially those who are very independent, driving here and there. They becomes very stuck that they cannot drive because of poor vision. Inability to complete their household duties for the housewife, or even for those who are working from home. Okay, unable to leave house without support. They always need someone to guide them. Impact the employment or ability to work. This is more seen in the younger groups, whereby they miss work because of their follow-up. They miss work because of they're not able to perform well, and this lead to poor economic production, right? And they also will develop a social, their social activities become more awkward because sometimes they feel embarrassed as they cannot recognize their friends or families' faces. I will touch a little bit on the difference between clinical trials versus real-world scenarios. I think everybody knows there's a lot of study have been done, especially in regards to the new anti-VEGF that has been developed. But we must remember that in clinical trials, the study design mainly addresses on the metrics of efficacy and potential safety, all right? And we have to follow the protocol adherence mandatorily. We cannot deviate because it's going to be a wrongdoing, all right? And there's a limited eligibility of the criteria. That means they have a very strict inclusion and exclusion criteria, and we can only involve those who are within the criteria in the study. And the treatment is always freely available as per study protocol. It can be as short as 12 months or as long as 72 months of the study period, depending on the protocol. However, in the real world experience, or in what the clinical situation that we are facing now, there's no protocol. Okay, so we have to understand the patient, we have to understand the disease process, and we must understand the outcome of the treatment that patient is going to get from our management. The burden of treatment is there, either for patient, for caregivers, as well for the private providers, because we are involving a wider population. Those that has been excluded from the study is actually to be treated by us as well. Okay, and treatment continuation, there's no limit in the treatment, but the treatment availability, the accessibility of the treatment is always a challenge. So that is two different things about real world scenario versus clinical trial. I'm not sure how many of you are aware, right, about the existing of DME management in the Asian population that was published last year. That was also an expert consensus guideline among the Asian retinal specialist in the APJO 2020. But that consensus is basically giving some ideas what is the treatment being practiced among the Asia Pacific retinal specialists. But we know that from years to years, there are many anti-vascular growth factors has been in market, and there's a lot of guidelines has been produced on what is actually the best treatment option. But we don't have one for our own Malaysia guidelines to give a reference or something for us to refer to when you need some advice in regards to how to use the first line agent, how to identify the responder, when actually we want to switch, what is the best loading dose that we need to follow. So therefore, few of the retinal, basically the medical retinal specialists have decided to sit down, and we brought in Dr. Adrian Koch, which is the well-renowned expert in the retinal related disease, okay, mainly diabetic macular edema, to help us to come out with this, our very own diabetic macular edema consensus guideline for Ministry of Health. So in this guideline, basically we are focusing on three main things. We are looking at the what are the imaging tools that we need in order to not only diagnose, but to also help in monitoring and give us some information on the prognostic, good or bad prognostic factors, in order to choose the best treatment, or what are the, how extensive we want to give the treatment. Then we talk about the treatment option, as well as the third things that we put in these guidelines is special condition to consider when we are treating our patient. So the risk of having visual loss or visual impairment in the population with diabetes is up to 25% higher than population not affected by diabetes. Okay, so we know that diabetes mellitus can cause blindness, and this is something that preventable. So something need to be done to ensure that those patients who are suffering from diabetes, hopefully they are not getting blindness due to diabetic macular edema. So first we are talking about OCT, optical coherent tomography. I think everybody knows about this. When we mention about OCT, everybody is so excited. Even during the exam, the first thing that we ask, what next you want to do, OCT is being mentioned. But what in OCT they want to look for? And what are the morphology pattern of DME that you should look for when you do the OCT? Okay, so first is the basic, looking for the retinal thickening. So the morphologic patterns of DME is the diffuse retinal thickening or swelling, presence of cystoid macular edema, evidence of serous retinal detachment, intraretinal fluid or intraretinal cyst. So basically these are the common features that you see when you have the patient with diabetes with significant visual impairment that presented to your clinic. So if you can look at, let me share the pointer, okay. The A is showing a diffuse retinal thickening. B is showing the vitreomacular traction and evidence of intraretinal cyst as well as intraretinal fluid. C is showing the subretinal fluid as well as intraretinal fluid, and D is showing features of intraretinal cyst with receptor formation and presence of intraretinal fluid. So when you look at OCT, try to look for all these features, but other than these features, there are extra things that will give you some information from the OCT. So this is where the prognostic markers on the OCT for DME will help you to prognosticate whether this patient is going to have a good outcome, this patient to respond well, or this patient is not going to respond very well to the treatment. So what are the things that you look for? The subretinal fluids and or evidence of small intraretinal cystoid fluids and or external retinal membrane and inner segment outer retinal inner and outer segment integrity, as well as is there any presence of vitreomacular adhesion. Okay, so what are the good predictor for the better visual outcome? If there's evidence of subretinal fluid, okay, so it's much better outcome compared to if there is intraretinal fluid. You look at the ellipsoids or the ISOS continuity, the inner and outer segment photoreceptor integrity, whether it's still there or not. Okay, absence of hyperreflective foci, and there's no vitreomacular traction, or there's no epiretinal membrane, or there's an attached vitreomacular interface. So this will give a good therapeutic outcome following your treatment. Otherwise, the disorganization of the inner retinal layers or drills, okay, is the anti of better prognostic biomarkers. That means it will give you information that the patient might not be responding or have a poor outcome as compared to those with the above criteria. Okay, so I mentioned about hyperreflective foci. What is actually hyperreflective foci? Okay, sometimes during the clinics, my specialist or my MO will come and say, oh, there's a lot of hyperreflective foci. What is it actually? So it's a deposit located within the wall of intraretinal microaneurysm and scattered throughout all retinal layers, which forming a confluent plaques in the outer plexiform layer. So you must always check with the clinical findings, yeah, with your color photo, whether that is actually evidence of area of vessels or that is actually just a plaque. Okay, so it is suggested that the foci represent extravasated lipoproteins and or proteins that may be a very early subclinical barrier breakdown signs in DME. So when you have that, you know that there's some inflammatory process happen, right? So the higher, take out the pointer, sorry. The higher, it's okay. The higher baseline number of this hyperreflective foci, it has a predictive value for the treatment response. Okay, and the CRT usually will be much reduced following the treatment with the anti-VEGF. So, what are the poor visual predictors in the OCT when you look at the patient with diabetes? First, I mentioned just now is the drill. Okay, disorganization of the inner retinal layer. You will see that the layer of inner retina is not well seen here. Okay? Everything is very disorganized compared to the one in the right side here. Okay? There's disruption of the inner and outer retinal segments. I mean, you look for the loss of integrity of the ISOS junction. So this area you can see very well preserved, but up to here, there's loss of the integrity of the IOS junction. So this might lead to irreversible photoreceptors destruction and loss, which give a poor visual outcome. However, sometimes if the patient is just presented to you with quite a recent blurring of vision, you always give the patient benefit of doubt, because I do see sometimes patients who presented like this following the treatment with anti-VEGF, everything comes back to normal, right? And the other thing is the thin subfoveal choroid at the baseline of the OCT. So if you do OCT and if you have the EDI component, please do it with the EDI to look for the choroidal thickness at the subfoveal region. Okay, the other investigative tool that we mentioned in the guidelines is the fluorescein angiography, but it is not a must thing to do during the first assessment or when you first see the patient. Usually, it plays an important role in the following circumstances. First, in indicating failure or inadequate response to treatment. Because sometimes you were looking inside the patient eye and you say that it looks okay, but why the fluid is not getting better with the treatment. So you might want to do FFA to look for, is there any evidence of subclinical area of capillary fallout? Okay, so if there is, you need to laser so that all the circulation, the perfusion, all that focus on the macula, and it will help in the response of diabetic macular edema to the treatment. Okay, second is in the determination of fovea A vascular zone or FAZ, especially when when OCT angiography is not available. So sometimes you want to see whether the poor vision is due to the enlarged FAZ, or in other words, is a macular ischemia. Okay. Third, we do angiography, like I mentioned, as a guide for supplementary laser. You want to know whether you need to give adjunct or supplement laser to this patient for the covering of the diabetic retinopathy condition. And also in the diagnosis of coexisting peripheral diabetic retinopathy, which require laser treatment. Okay. So when you want to treat your patient, what are the points that you need to consider? First, of course, we want to look at the baseline visual acuity. Why you want to look at the baseline visual acuity? Because you want to tell the patient what actually to expect when you treat the patient. Okay, some patients have a very good vision, 612, 6/9, but there is evidence of central involvement, macular edema. So if you want to treat, you don't say that it's going to improve your vision very well. The vision is only considered good. So patient might not be able to differentiate pre and post treatment. But when you have patient that have a significant poor vision, you might happily want to say that it will improve your vision and the patient can see the difference. The other thing is when the patient at presentation baseline is very poor due to, let's say, very impacted heart exudate. So you know that you're not supposed to explain to the patient of the vision, high vision expectation. The impact heart exudate might not resolve and the patient vision might not improve very much. But overall, you want to save the macula from other damage. So sometimes we still treat this patient. Okay. Other point to consider is, of course, duration of diabetic macular edema. Sometimes it's very difficult, especially if this the first time patient presented to you. Other than those who refer to you, they have been lasered for many times, or they have been there, patients still thinking about the treatment. So you know that this is a chronic condition. So it will alter your treatment responsiveness. Right? Then the third thing that you need to consider is ocular environment and also local pathological changes. For example, if there's a ERM presence, if there's evidence of very hard exudate smack on the macula. So that is something that you need to consider, what to choose for the patient, how aggressive to treat the patient. Okay. The next one is wearable treatment responsive to anti-VEGF, steroid, and laser suggests presence of multitude of pathogenic pathway. That means that some patient you have tried your best, but they're still not responding. So you have to look for what other possible systemic condition, where the next factor that I'm going to mention is what are the systemic factors. Actually, is the patient is controlling the diabetes? Is the patient controlling the other risk factors that they have? Okay, so it's not surprise among our Malaysian patients, despite we are treating their eyes, injecting their eyes every month, they are still not controlling their diabetes. Okay, they are still happily not compliant with their diabetic medication. Okay, so if you ask your patient what is their best HbA1c, most of the time our diabetic patient, their best HbA1c is about 8. If they won't reach up to 6 or even 7, the one that proposed by our endocrinologist. So what are the treatment? The next one is about the treatment option. So what are the treatment option or treatment available for management of diabetic macular edema? In this era, okay, we are very lucky because we have multiple anti-VEGF in market. We have steroid, which is the one that been proof is Dex implant or Ozurdex. We don't have fluocinolone in Malaysia, and triamcinolone, of course, freely available, but it is currently off-label treatment for ocular use. Okay, we have laser, either giving grid or focal, and of course, surgery, which is vitrectomy in certain cases, which I will mention later. So anti-VEGF for diabetic macular edema is always like the first line treatment in our common practice. Okay, so indicated as first line in patient with symptomatic central involvement DME, all right, phakic patient, or patient with very advanced glaucoma that you are not able to give steroid as the first choice. So if you look at the Asian consensus guidelines, every agreement was majority loading at 3 injection. All right. However, early intensive therapy is recommended in this consensus, and ideally we give about 5 to 6 initial monthly loading phase. Yeah. So monthly injection for 5 to 6. With a total injection in the first year about 8 to 9 injection. Okay, this is to control the inflammation within the eye, so that we can have a better quiescent response of diabetic macular edema. Okay, and the follow-up strategy, of course, we open for the doctors to choose whether you want to fix the treatment at monthly or 2 monthly. You want to give it as a reactive treatment as a PRN basis. That means you call the patient every month, but you might not give the treatment if there's no signs of disease activity, or you can start to treat and extend protocol, whereby you extend the follow-up, but each visit, irrespective of disease activity, you are still treating the patient with the anti-VEGF to make sure that everything is under control. So when actually we switch either from one anti-VEGF to the other anti-VEGF, or from anti-VEGF to the steroid, is usually we give it a time. Okay, if there's no response after 5 to 6 injection, then there is where you should reassess the patient by doing the investigation that I mentioned earlier, or if you want to consider to switch without doing, you have to bear which one, whether you want to change to the anti-VEGF or to the dexamethasone treatment. Okay, so people will ask which anti-VEGF is the best. So if we look at the previous study, the protocol T, yeah, actually has proven that any type of anti-VEGF is non-inferior to each other. Okay, so the steroid implant usually is indicated as the first line if you already know that the patient is high risk of cardiovascular disease. High risk of cardiovascular disease, a patient is recently having heart attack or develop some or having a bypass within the first 3 months, that is relative contraindication. That means you're not supposed to give anti-VEGF because you want to make sure that the heart is healing well. Those who have unstable angina but not getting any treatment at the moment, so that is considered as high-risk cardiovascular patient. So this group of patient, you still need to treat. So steroid is actually the choice of treatment. And in some situation whereby diabetic patient who are pregnant and develop significant macular edema, whereby you cannot give anti-VEGF, so steroid implant is still one of the treatment of choice. So you can see here the relative indication. Okay, again, patient with poor compliance that cannot follow your loading phase schedule. Okay, pseudophakic patient is actually a relative indication for steroid implant, but you shouldn't be giving the patient with ACIOL or aphakic patient. Okay, patient who scheduled to undergo cataract surgery, right? So you may consider this as your first treatment implant as well, and patient with history of vitrectomy. And how to monitor the patient while they are on Ozurdex or steroid implant is to continue assessment and continuous assessment. Usually the first 6 weeks, you will call the patient for the follow-up. Then you can see the patient in about 2 to 3 months later to see the progress of the condition. And you can only repeat the injection as per formulary KKM approval is after 6 months. That means one patient only to receive 2 injection per year. However, I think from our experience, we know that at the end of 4 months, patient already started to wean off of effects of the steroid. So they already started to develop some form of recurrence of macular edema. Okay. So when we talk about steroid implant, there's 2 things that always come across as a side effects. First is we are worried about possibility of raised intraocular pressure. Second is about development of the cataract. So the study have shown that the significant IOP raise is not of significant, and if there's evidence of high IOP, it can be treated with IOP lowering agent. Right? It's not many patient actually requires up to the surgical intervention following this condition. And for the cataract, of course, as per indicated in our formulary, it is only for pseudophakic patient. But in the patient that they are not eligible for anti-VEGF because of the high-risk condition, this can be used as a off-label. That means you need to get the capital approval to insert this Ozurdex in the patient. And if they develop cataract can easily be treated with the cataract extraction and IOL implant. But you have to explain to the patient the risk of this treatment and the significance of having the insignificance of having the side effects of the steroid implant. Okay, so is laser still play a role? Definitely yes. Okay, for those non-center involvement DME, laser is still the treatment of choice. Okay, and you can also give rescue laser for central involvement DME, but you have to make sure that your anti-VEGF treatment has been maximized prior to giving the laser. And we review or can repeat the laser after 3 to 4 months time if the patient is to get this condition. The laser side effects, of course, if you are giving focal laser, not much of color vision or night vision impairment. Yeah, but if you are giving a grip, the patient might having some form of color vision defects at the center because of at the center area. And if you give too much of power, you will be surprised patient might develop secondary CNV or even central scotoma. So performing a laser, the right power, the safe area to laser is always an important things to look at. All right. So PPV and membrane peeling is to be done if there's a case of tractional macular edema or a significant epiretinal membrane. And this is always we need to deal with the vitreoretinal colleagues to get the agreement that surgery is indicated in this kind of condition. So overview, these guidelines in the management of DME is to standardize the best treatment option for the condition and to give the ophthalmologist current knowledge on the latest practice pattern and the need to timely referral to the retina specialist for further management when necessary. So we put there a case of central involvement DME, what to do. Okay, central involvement DME, but with a very good vision. What are the advice that we need to do? You can observe, you can give focal laser, or in certain situation, after discussing with the patient, you might also offer anti-VEGF treatment. However, in non-central involvement DME, you can give a focal or grid laser, but you must always putting the risk and benefit of anti-VEGF if you are keen, okay, or patient is keen to have it done. Because sometimes patient comes to you with no idea what is inside the eye. They just been told that there's a macular edema, and they might think that anti-VEGF is the treatment for everything. So as a doctor, as a retina specialist, or as an ophthalmologist, you have to be sure of the indication, and you must be able to advise the patient accordingly. Okay, so regarding the special condition when you are giving or when you are treating macular edema, is of course to look at the blood sugar control. All right, if the patient HbA1c is very poor, please write a note to the doctor, their family medicine doctor, or the GP that they're having the medication, or the KKs that they're having the follow-up, to control, to optimize their blood sugar control, to optimize their blood sugar. And also if they have other comorbidities such as hypertension, need to be controlled as well. So in the patient of diabetic macular edema, and you are planning for cataract surgery, or patient also having a significant cataract, make sure that the diabetic macular edema is stabilized prior to the cataract surgery, okay? And if the patient just stable and you need to do it urgently because you need to look at the macula, at the retina in detail, so you can give anti-VEGF prior to the surgery or perioperatively, anti-VEGF or DEXA implant depending on the situation, right? So patient, as I mentioned, patient with DME and pregnant, all right? Is there a role or contra indicated for anti-VEGF? Actually, for during the first 2 trimesters, it is not advisable because it has been reported a case of they lost the baby, okay, miscarriage, abortion, all that occurred when anti-VEGF was given during the early pregnancy. However, at the end of the 3rd trimester, there's few school of thought. Some say it's safe to be given, but I think best to avoid, as we have other option of DEXA implant to give to this patient. Okay, and always remember the risk of endophthalmitis. And if you are putting the Ozurdex implant, don't take the chance to say that this is a pseudo endophthalmitis, because you do sometimes develop a massive inflammation following the steroid implant. But always think of endophthalmitis as one of the as the main complication when patient come back with severe inflammation inside the eye. Patient with pre-existing glaucoma, yes, you need to be cautious, all right? Make sure that patient continue. And if you need to give steroid to this patient, please co-manage with your glaucoma specialist so that monitoring and planning for a more extensive treatment can be planned for the patient, right? In the patient with the vitrectomized eye, anti-VEGF efficacy is not well established due to increased clearance of the molecule. And for the DEXA, it seems to be more effective both in the vitrectomized and non-vitrectomized eye. So these are the few things that you need to take into consideration, yeah, when you are planning for your patient management. So this slide is quite busy. Basically, this is the most important thing where we put it all together here, the algorithm for the DME as per our MOH consensus 2021. So we divided into 3 main things, using anti-VEGF, using the intravitreal steroid, but we are talking about dexamethasone implant here, which is the one that been approved for the usage in Malaysia, and other treatment which include laser, either focal or grid, and TPPV. So you can look into this. I'm not going to explain about this algorithm. So we also add in the definition of treatment response. What do we mean by adequate response? Okay, so when we have vision, the target response is to have vision 6/6, or the central macular thickness of less than 300 micron. So adequate response if you have a vision of 612 or better with the CMT of less than 300, okay, and you must look at the CMT improvement more than 10% after treatment. So this is where OCT in each visit is very important. If you don't have OCT and you treat the patient, how sure are you to say that you need to switch because patient is not responding, or how sure are you to say that the patient is responding to treatment? Okay, inadequate response in those who has a poor vision, less than 612, and the central macular thickness is still more than 300 micron, and there's no change of the central even after your first, second, third, or fifth anti-VEGF injection. And non-responder are those who has no improvement even after your 5th injection. Okay, so before I end, these guidelines is available in College of Ophthalmology's website as well as MSO website. You all can look into it and can use as your guidance. All right, thank you very much for your attention.
DME is one of the causes of vision loss in diabetic retinopathy, with an increased prevalence of global epidemic in type 2 diabetes mellitus. Understanding the foundation of treatment for macular edema is therefore an important necessity. Now, we would like to open the floor to all the participants. If you have any questions to Dr. Fariza, please put your questions in the Zoom chat box. Dr. Fariza, we have a first question for you. How do we decide giving loading doses of 3 or 5 injections on the initial diagnosis?
Okay, for my practice, usually we put the loading phase as 5, right? But again, it depends on the availability of the anti-VEGF. So as per Asian consensus, because different country actually they have a different subsidized pattern for the anti-VEGF. But for our Malaysia, we are very lucky. Yeah, most of the anti-VEGF has been subsidized fully. So to get the best treatment, everybody agrees actually the 5 loading dose is the best. But during the monitoring, after 3, sometimes you can reassess and see whether the patient is responding or not. If let's say the patient is not responding well, or patient is totally better after the 3rd, we do make the decision to say that from here we extend the treatment. But if the patient is still having evidence of subretinal, intraretinal fluid or disease activity, we will continue until the 5th or 6th treatment. Okay.
Dr. Fariza. Second question, what are the absolute contraindications or absolute contraindication for DEX steroid implant?
Absolute contraindication is patient with ACIOL or aphakic patient, or patient with advanced glaucoma or uncontrolled glaucoma. That's the only 4 that usually we say no to this DEX implant. But the rest is basically just a relative contraindication that we have to see from case to case basis.
Another question that we usually encounter during cataract pre-clucking is, how long do we have to wait for patient with recent MI or recent stroke with DME, central involving DME, to be given anti-VEGF after considering alternative treatment?
Okay, usually I will take about 6 months. Okay, 6 months if the patient is asymptomatic and the patient is actually under treatment, right? Sometimes patients say, okay, I have chest pain. It was 6 months ago, but it was never investigated. So we are worried whether patient requires any intervention or not. So we have to refer the patient first. But if let's say the patient say, oh, I have MI and something stenting done or some bypass done, so you give it about 6 months. Okay. if it's really, really indicated, usually you have to liaise with the cardiologist, because we know that when they have the MI, they need the VEGF to allow the anastomosis of the small vessels in the heart. So if you give the anti-VEGF, the anastomosis won't happen. So the patient might get a failure of the surgery, might get another attack of MI. Okay, so the best is to wait at 6 weeks if the patient can give you all the information of their cardiac status.
Okay, Dr. Fariza. Another question from the participant. Is there any role of anti-VEGF in case of patient with active DME with subretinal fluid with subretinal fibrosis on OCT?
Okay, so you have to look at the how bad is the fibrosis. Okay, usually are you talking about is it fibrosis or heart exudate? Okay, because usually DME they don't develop much of fibrosis as compared to AMD. So you have to look at the patient baseline vision. If let's say the vision is about 624, you know the potential is still there. So give patient benefit of doubt. Usually I will still treat the patient. And again, we look at how much is the subretinal fluid, because you mentioned subretinal fluid, not the intraretinal fluid, right? How much or how significant is the subretinal fluid? If it's very minimal, like a very tiny area of subretinal fluid, that is the one that we can observe first. But if there is a significant height of subretinal fluid, yes, I will treat those patients. So there's a lot of things to look at in the OCT, yeah, when you deal with patient with either DME or even AMD. Mentioning SRF only is not enough. You have to look how significant is the fluid in that area of interest. Yeah.
Dr. Fariza, we have a question from the Zoom chat box regarding intravitreal injection before cataract surgery. What do you mean by pre-operative surgery? Do you mean the same setting during cataract surgery?
No, that one is peri-operative. That means after the operation you give. Pre-operative, that means you give about usually the longest time that we propose before the surgery is about 2 weeks, but it should be done 1 week prior, because you want to ensure that inflammation is under control. And if you need to re-inject after the cataract, you have about another 3 weeks after the cataract surgery before you interfere with the pseudophakic eye. Because sometimes if you give too much earlier, by the time patient requires 4 weeks later, it's a bit too close after the operation. The injection might cause opening of the wound, all that, because sometimes you do phaco without any suture, right? So you don't want to disturb the wound. So usually 1 to 2 weeks prior to cataract surgery. That is what I mean by prior to cataract surgery.
Dr. Fariza, in district hospital where OCT is not readily available, do we have any preferred practice for DME?
Okay, so I know that OCT is not readily available in the district hospital or even in a main hospital. Okay, so the best practice is before you plan for injection, have one OCT. Okay, because you want to have a baseline OCT to see whether there's improvement or not. Then you give 3 injections. After the 3, you must have another injection, another OCT to see how is the response. Then 1 more after the 5 or the 6 injection. But if the patient can afford to go to the nearby center just for the OCT, it will be good to have it every month monitoring. Okay, so we are trying our best, yeah, to have the OCT in all hospitals. So hopefully 2023 is the something will happen, magic will happen, that everybody will have the OCT, so that all the patient will get the best treatment for their DME condition. Yeah.
Dr. Fariza, we have another follow-up question regarding MI. In a patient with IHD but refuse cardiac intervention, can we offer intravitreal DEXA instead or Ozurdex?
Yes, that is the patient is who's actually indicated for the DEXA treatment. Yeah. So if your patient is actually pseudophakic, it's already in the formulary. Okay, you can order and give the treatment if the hospital got money lah. Because there's no special fund, you're still using your hospital budget. But patients who are phakic, you need to get the capital approval before you can give the injection.
Dr. Fariza, with regards to patients with central involving diabetic macular edema who have inadequate response or no response to anti-VEGF that requires grid laser, is there a limited number of times that laser could be applied?
There's no limited number, but you can only repeat if already patient already on anti-VEGF, you give after 6 months, and you can only repeat as usual 3 to 4 months later. You cannot be, you have to assess first the response of your first laser. So after 3 to 4 months, if the patient still not responding, then you have to, you can repeat laser. But usually from my experience, patients who are on anti-VEGF that need adjunct laser, most of the time they only need like one time laser, and they are quite responded to that treatment.
Thank you, Dr. Fariza. Is there any more questions from the participants? If there's no more questions, I would like to conclude the session, and thank you, Dr. Fariza, for the wonderful presentation. I'll pass the floor back to the NC.
Thank you.
Thank you, Dr. Fariza and Dr. Anwar. That was a very informative Q&A session. We will now proceed to the next half of Surgical Retina Symposium. I will now pass the floor to Dr. Yap.
All right, thank you, Madam MC. Okay, we will begin our second sessions of Surgical Retina Symposium. I would like to welcome again all the participants. Reminder, please leave your questions in Q&A box or chat box, and we'll have our speakers to answer your questions at the end of the session. So without further delay, I would like to introduce our first speakers of this session. Our first speaker of this session is Dr. Peter Kong. Dr. Peter Kong is currently the Vitreous Retina Consultant in Synergy Specialist Eye Center in Kota Kinabalu, Sabah. Dr. Peter graduated from UM in year 1991 and obtained his Master of Ophthalmology from UM in 1998. He then pursued his Vitreous Retina training in UK. He was the head of ophthalmology department in Queen Elizabeth Hospital, and he started Vitreous Retina service in Queen Elizabeth Hospital. So today, Dr. Kong will present on topic of macular hole. As we all know, there are various stages of macular holes, and we are often confused in the regards to the best or most appropriate timing for surgical intervention. Fret not, today Dr. Kong will enlighten us on the prognostic factors and surgical techniques on macular holes. So let's welcome Dr. Peter for his presentation.
This is Peter Kong from Synergy Specialist Eye Center, talking on macular hole, surgical technique and prosthetic factor. First of all, I would like to thank the organizing committee for inviting me to talk in the Borneo Ophthalmology Update 2022. This is overview of my talk. Full thickness macular hole is the defect of the foveal retina involving full thickness from the internal limiting membrane to the outer segment of the photoreceptor layer. Gus in 1988, with his astute clinical skill using SIPLAB, have divided the macular hole into 4 stages. This is further validated by the advent of OCT. This table summarizes the finding in the Gus and IVTS classification. Basically, in the IVTS classification, they look into 3 additional factors, that is the size, the cost, and the visual macular traction. In stage 0, there is visual macular attachment. Stage 1, impending hole. Stage 2, small macular hole less than 400 micron in size. Stage 3, 400 micron or bigger. And stage 4, there is complete vitreous separation. The importance of studying is that each stage has a different natural history. In stage 1, 50% of the hole may regress and only 40% may progress. In this group, observation is all need to be done. Whereas in stage 2 to 4, the disease will more likely to progress and thus need surgical intervention. The pathogenesis of macular hole arises from the remaining vitreous cortex in the macular area after the vitreous have separated. This new vitreoretinal interface force will direct the fluid to concentrate on the macula, causing swelling of the middle and the outer retina with elevation and retraction of the inner retinal layer. As the swelling increases, the hole will become enlarged. Based on this understanding of the pathogenesis of macular hole, Kelly and Wendell propagated the concept of pars-plana vitrectomy, induction of PVD, removal of posterior vitreous cortex, free gas exchange, and face-down positioning for the repair of macular hole. In 1990, out of the 52 eyes they operated, they achieved the anatomical closure rate of 58% and visual improvement in 42%. To improve the outcome, various modifications have been done. This includes internal limiting membrane peeling or forming a scaffold for the glial cell proliferation, either using the native retina tissue or implantation using the lens capsule or amniotic membrane graft. Ecker in 1997 introduced the ILM peeling concept. This removes all waste of vitreous cortex, relieves the tangential traction caused by the glial cell, and also reduce the scaffold for cell proliferation to potential epiretinal membrane. The problem with ILM peeling is that it can potentially cause direct mechanical damage to the retina, causing a paracentral retinal hole. Potentially, it can damage the molar cell and plaque, leading to a condition called dissociated outer nerve fiber layer. This appears as a small spindle-shaped splitting of the nerve fiber layer adjacent to the pupil edge, but fortunately, it doesn't affect the final vision or the macular sensitivity. There may be a risk of phototoxic damage or from chromophore toxicity from the ICG used. To minimize complications, a few modifications have been proposed. The first one is fovea sparing ILM peel, where the ILM is left at the fovea there, leaving fovea to have a better contour, less retinal damage, and better visual outcome. The second one is the temporal ILM peeling, whereby it spares the papular ocular bundle area from possible detrimental effect of the ILM peeling. This also prevents nasal displacement of the retina. ILM peeling is good for repair of a small macular hole. However, the result is not as good as in large or recurrent full-thickness macular hole. In this type of cases, a scaffold for glial cell proliferation is used, and the first one to be used is actually the inverted flap, which acts as a scaffold and stimulates the glial tissue proliferation on the cell surface and growing into the hole and retina. It also serves as a barrier, preventing fluid from the vitreous from entering into the hole. This microenrollment encourages the photoreceptor to move into the correct position. When the ILM is present at the macular hole, the ILM flap technique is used. they aim to lift the hinge attached and prevent the loss of the ILM flap. The flap can be plugged inside, as in a folded inverted flap technique, or the cabbage leaf technique, or it is left on top, either as the temporal ILM inverted or pedicle ILM technique. I usually combine my vitrectomy with phacoemulsification for my macular hole case. I routinely use BBG dye, which is injected directly under the fluid. I use heavy water preparation in the brilliant peel, which settles over the posterior pool and does not disperse. Sometimes I use the regular BBG from overlap, and after clamping the infusion to prevent dispersion. I usually keep the dye for about 60 seconds. I prefer to use a self-stabilizing contact lens, which eliminates the cornea asphericity and therefore provide a better vision and depth perception, and it is not affected by fogging. I use the pinch technique to initiate peeling, usually quite near to the retina vein, either superiorly or inferiorly. This is done by using the ILM forceps. After creating the initial flap, I now create the opening in the temporal arch. And thereafter, I slowly, gently grabs the edge of the free temporal flap and pull it towards the hole there, slowly, making sure that I don't extend the peeling beyond the edge of the hole in 270 degrees, so that the hinge remain attached on mainly the temporal side. Thereafter, I continue peeling the rest of the ILM slowly, and the peeling motion is almost similar to the rexis, circular and tangential to the retina surface. If at any point the nerve layer fiber is grabbed, you release and start again, and do not keep pulling in that case, otherwise cause a retinal injury. Usually I peel towards the arcades, and also around 2 disc diameter away from on the temporal side, and till the disc on the nasal side. Next is the trimming of the excess fat from the nasal side using a lower vacuum. With a temporal hinge, usually the flap will lay over the macular holes towards the optic disc. A metacellulose tamponade is used to secure this placement by injecting towards the temporal part, and it will flatten. Finally, a fluid air exchange is done by placing the back glass over the optic disc directly while aspirating the fluid. There is no attempt to remove the metacellulose. The air is exchanged with non-expansor sulfur hexafluoride. If there is no ILM around the macular hole, such as in the redo case, then the fold have to be obtained from elsewhere, either from the ophthalmologist ILM flap, or from the graft, or implantation. In the ophthalmologist transplantation of the ILM free flap is taken from the area of the residual ILM, the same size as the macular hole, and this is tapped by placing low molecular weight viscoelastic for stabilization before the fluid gets exchanged. The autologous neurosensory retinal flap is used for refractory cases, especially highly myopic macular hole, in which the thin ILM precludes safe and adequate peeling. The flap is usually taken just outside the posterior pool and is placed on top of the macular hole, and this will help to seal the hole by forming a macular plug. The lens capsule is a natural basement membrane and can be used to plug the hole. Chen and Yan used this in 20 of the cases. They combined cataract and macular hole surgery together. The flap was gravitationally dropped into the macular hole, followed by the air fluid exchange. The results show that there are 100% closure in the anterior capsular flap and 50% closure for the posterior capsular flap. And the vision had mildly improved following the surgery. The human amniotic membrane shows excellent growth support for the RPE cell and induced RPE cell proliferation and differentiation. The Italian group have used this for recurrent macular hole and with great anatomical success. Apart from dealing with internal limiting membrane and using scaffold as a glial cell proliferation, relieving macular hole stiffness and increasing retinal compliance are two other surgical concepts in macular hole surgery. This can be done either by tapping the hole edge, doing a temporal arcade retinotomy, doing a high-dose dissection for the macular hole, or induction of the retinal detachment. Kumar et al. Introduced the concept of tapping hole edge following the observation that the MH index with more than 0.5 has significantly better post-op outcome. And by using a silicone tip drainage, this could improve the closure. Steve Chance pioneered the temporal arcade retinotomy in large full-thickness macular hole surgery. He used a 25 gauge curved scissor to create a full-thickness temporal incision. In this way, it split the nerve rather than cutting it. The resulting retinal bridge is then displaced nasally using a soft-tip cannula to reduce the horizontal diameter of the hole and changing it into a vertically oval shape. Felili et al. Described a macular hole hydrodissection method, where he lines the adhesion between the retina and the RPE by passing fluid into the macular hole using the reflux mode of the vitrectomy directed at the area of macular hole. Because of this, it will result in the reduction of the stiffness of the retina, and the retina become more compliant. In a more aggressive move, Zigeto et al. Described an induction of the macular hole detachment technique for treating persistent and recurrent macular hole. This is achieved by injection of the BSS into the subretinal space in multiple quadrants, and this method releases the adhesion and allow the hole to approximate and close. Another concept in macular hole surgery is using a liquid plug to promote corneal retinal adhesion. The autologous hole plug can be used to maintain the internal limiting membrane flap in place. Various autologous plug products can act as a slow-release fibrin matrix, which contains several growth factors and cytokines to promote healing. This can be in the form of autologous serum, autologous platelet plasma, or thrombin. This table summarizes the outcome of the surgery on large macular hole using various surgical techniques. The best result is seen in the ILM flap group, usually in excess of 90%. In the persistent or recurrent macular hole surgery, there are more varied surgical techniques with variable results. Due to the small number of cases, most methods have not accepted into main practice. This is a surgical scheme for full-thickness macular hole as proposed by Intermission. Macular hole is divided into primary or persistent. In primary group, if it is small and good vision, you may opt to observe, or you may consider a post-planar vitrectomy with ILM, peeling or flap, followed by a gas tamponade. In the case of persistent or recurrent macular hole, if there is inadequate ARM or ILM removal, then you can repeat the post-planar vitrectomy and extend the original peeling or put an ILM-free flap and end up with a tamponade agent. However, if there is no tissue available, then you can consider doing a post-planar vitrectomy and with other various methods. This cartoon shows the healing process of a macular hole following surgery. There is initial glia proliferation, followed by external limiting membrane bridging, and later it is followed by glia elimination. Once glia is disappeared, the ellipsoid zone will be restored, followed by complete photoreceptor reconstruction with cone interdigitation zone restoration. Not all patients recover in this way. There may be some delayed visual recovery following impaired healing process. Let's look at the macular hole closure pattern. In 1999, EMI first looked at the closure pattern based on the time domain or CT. It described based on the corneal contour, type U as in normal OCT, V show the steep forward contour, and W show the forward defect of the neurosensory retina. Kang further simplified the classification based on the presence or absence of the forward neurosensory retina defect, type 1 being no interruption and type 2 there's an interruption. With improvement in the technology of OCT and surgical technique, Thomason, Ross et al. Have proposed a new classification based on retinal layer reconstitution, and it also allowed the description of closure pattern typical of the newer surgical technique. There is a correlation between the classification based on the retinal layer constitution and both the visual acuity and the surgery adopted. In stage 0, the hole is open. In stage 1, the hole is closed, either with TPP with ILM peeling or flap. In stage 2, the hole is closed from either using the autologous or heterogeneous filling tissue. Let's look at some prognostic factors which predict the clinical outcome. The prognosis will be better if the presenting vision is 630 or less, the size is 250 micron or less, then duration of presentation is less than 6 months, the younger age patient, and we do the surgery area. Surgery costs usually confer a poorer prognosis, for example in the case of trauma or vascular disease. OCT is important in staging the disease and also help to identify surrounding epiretinal membrane, cuff fluid, visual fovea extraction, operculum or pseudo-operculum, and status of the RPE. It also allows calculation of various macular hole indices that have a role in prognostication. What are the OCT features that we see before we do the surgery? The prognosis is better if the hole is small, if there is cystoid changes at the edge of the macular hole, and if there is intact of the retinal layer, such as the external limiting membrane and the IS-OS junction, or a higher hole forming factor that is greater than 0.6. The prognosis is poorer if the retina is thin and atrophic, and if there is irregularity of the photoreceptor layer after the successful macular surgery. These are the macular hole indices with various definitions and ways to calculate it. Character macular hole index and tractional hole index are associated with better post-op functional outcome. The macular hole index predicts the external limiting membrane restoration. The minimal linear diameter and the base diameter are predictive of anatomical closure. Fundus autofluorescence is another test for prognosis in case of macular hole. Absence of the foveal pigment in macular hole leads to hyperautofluorescence of healthy RPE. Therefore, poor autofluorescence is associated with the poor visual prognosis. In summary, macular hole is treatable even in the large refractory or recurrent cases. OCT assessment is important for staging and prognostication. In terms of surgery, post-planar vitrectomy with ILM peel or flap is still the mainstay. Eye with shorter duration, smaller hole size, and higher pre-op visual acuity achieve a better outcome. I thank you for your attention.
Thank you, Dr. Kong, for your wonderful presentations. We have a number of questions, but we'll discuss it at the end of the session. For the participants, if you have any questions, you can continue to put in the chat box or Q&A box. So I shall introduce the next speaker. Our next speaker is Dr. Sheena Mary Alexander. Dr. Sheena is currently our HOD in Queen Elizabeth Hospital. She is also a Vitreous Retina consultant. She graduated from Kasturba Medical College in 1992, and she obtained her Master of Ophthalmology from University of Malaya in 2004. She then completed her Vitreous Retina subspecialty training in year 2009. Dr. Sheena's topic today is on proliferative vitreous retinopathy. As we all know, PVR is a complication of rheumatogenic retinal detachment, and its management can be very difficult. So without further delay, let's welcome Dr. Sheena. She'll be presenting on the understanding and management of proliferative vitreous retinopathy.
A very good afternoon to everyone, and thank you for joining us in this session. My topic for today is proliferative vitreous retinopathy. Proliferative vitreous retinopathy is the most common cause of failure of surgical treatment for rheumatogenic retinal detachment. It is characterized by a wound healing response and formation of surface membranes in the posterior segment. Membranes most commonly form on the inner surface of the neural retina, but can also occur in the subretinal space, vitreous base, and on the ciliary body. Contraction of these membranes cause macular pucker, new retinal breaks, recurrent retinal detachment, and ocular hypotony. PVR occurs following surgical repair of retinal detachment, but can also occur in untreated cases with long-standing or large retinal breaks. It occurs in about 5 to 10% of treated rheumatogenic retinal detachment cases, and it can also occur in untreated retinal breaks, particularly large and multiple breaks and large choroidal detachments. Young patients with penetrating ocular trauma, especially double perforating injuries, also have a very high risk of PVR. This flowchart shows the interaction of various factors in the pathogenesis of proliferative vitreous retinopathy, from the initial retinal detachment to the serious complications of recurrent detachment and hypotony. The primary event is the formation of a retinal break. It is followed by retinal response to injury with retinal glial cell activation, which plays a major role in the PVR development. RPE cells then migrate through the break into the pre-retinal space where they settle on the retinal surface. Gravity influences the distribution of RPE cells to the inferior retina. Glial cell proliferation and extension of glial processes to the epi and subretinal spaces follows. These cells take on characteristics of myofibroblasts that have contractile properties and lay down collagen, and inflammation and breakdown of the blood-retinal barrier are associated with cellular recruitment, followed by inflammatory mediators and the formation of extensive fibrous membranes. Collagen is produced and the membranes then contract. The whole cycle from PVR formation to redetachment of the retina takes about 4 to 6 weeks. Certain types of retinal detachment are more likely to develop PVR than others. RD associated with giant retinal tears have a high incidence of post-operative PVR due to the large area of RPE that is exposed. Other risk factors are the number and size of retinal breaks, the number of previous operations, the presence of choroidal effusions, the use of cryotherapy, intraocular hemorrhage, high vitreous protein levels, and the severity of pre-op PVR. Young patients who have penetrating trauma, especially double penetrating injuries, also have a very high risk of PVR. PVR consists of a clinical spectrum ranging from minimal epiretinal membrane to a total funnel-shaped retinal detachment with retina adherent to the ciliary body and iris, which results in hypotony and phthisis bulbi. The earliest signs of PVR include vitreous flare and clumps of pigment in the vitreous. Increasing stiffness of the retina is then noted when patients move their eyes. The edges of the retinal breaks may be rolled over as a result of contraction on one surface only, and retinal breaks may appear stretched. Star folds are localized areas of puckering in the detached retina after focal or localized contraction. Subretinal fibrosis may be present. Significant amounts of surface traction cause retinal shortening. More severe contraction pull the retina inwards, leading into an anterior funnel appearance. Contraction of the vitreous base leads to circumferential shortening and anterior loop contraction. Surface membranes on the ciliary body may compromise aqueous production, which results in hypotony. This picture shows a contracted surface membrane causing shortening of the retina. PVR causes a raised roll appearance of the margin of tears due to the contraction of surface membranes. The tears are also stretched open. Subretinal fibrosis can be diffuse or band-like. In this image, you can see a subretinal fibrous band passing close to the fovea. Star folds are focal areas of puckering after localized contraction. Contraction of the anterior vitreous produces a funnel configuration of the retina. The image on the left shows a funnel-shaped retinal detachment seen by B-scan ultrasound. This table shows the revised Retinal Society classification of PVR, which has been used in clinical trials of treatment. In grade A, vitreous haze, pigment clumps, and decreased mobility of the retina is seen. Grade B includes inner retinal wrinklings, stiffness, and rolled edges of retinal tears. In grade C, there are full-thickness retinal folds either anterior or posterior to the equator, and the anterior or posterior extent in clock hours has to be noted. In type 1 grade C, there is focal posterior contraction or star folds. In type 2, there is diffuse posterior contraction. In type 3, there are subretinal bands or sheets, and in type 4, there is circumferential contraction of the posterior edge of the vitreous base. In type 5, there is anterior displacement of the vitreous base. The differential diagnosis of proliferative vitreoretinopathy includes proliferative diabetic retinopathy with TRD, chronic retinal detachments with retinal edema, severe choroidal detachments, severe vitreomacular attraction syndrome with TRD, and severe ocular hypotony. The objective of vitreoretinal surgery for PVR is to permanently support the retina from any ongoing traction and to close any open retinal breaks. Almost all eyes with retinal detachment and PVR also require a meticulous vitrectomy to remove all the vitreous gel, cellular, and inflammatory material. The peripheral vitreous should be removed as completely as possible, including blood and fibroblastic membranes. Vitrectomy is followed by the peeling of surface membranes using a retinal pick and microforceps. It's important to relieve all traction associated with breaks. Heavy liquids can be used to assist the process of membrane peeling, and macular pucker will also benefit from membrane peeling. A scleral buckle can be performed with or without vitrectomy. The scleral buckle place should be high to ensure permanent support of the vitreous base. In the absence of retinal breaks, PVR does not require treatment unless the macula is involved. A circumferential buckle should be placed to support the vitreous base, which is typically shortened circumferentially. If the peeling of retinal membranes is insufficient to relieve retinal shortening, further dissection of the vitreous base or a relaxing retinotomy is performed. Subretinal bands can be removed if necessary. It can be divided through a small retinotomy or pulled out hand over hand, as they are usually loosely adherent to the overlying retina. Wide field chandeliers may improve visualization and allow bimanual membrane peeling. Break should be treated with laser photocoagulation. Laser is superior to cryo as it can seal flattened retinal breaks and allow 360 photocoagulation with less post-operative inflammation and simulation of repeat cellular proliferation. Air fluid exchange, retinopexy, and long-term tamponade with C3F8 or silicone oil should be used. Outcome of RD surgery with C3F8 gas and silicone oil are found to be similar in various studies. Many surgeons prefer silicone oil due to less post-operative inflammation and quicker rehabilitation. The use of heavier than water silicone oil can also improve inferior retinal tamponade in severe cases of PVR. Silicone oil may be removed after 3 months. Delayed removal for up to 18 months does not improve functional outcomes. Phacoemulsification can be carried out at the time of surgery or during removal of silicone oil. Many eyes with PVR continue to develop surface retinal membranes after retinal detachment surgery, causing macular pucker, inferior detachments, retinal tears, and shortening. It is possible to remove these membranes under silicone oil or heavy liquids. Silicone oil does not have to be removed before membrane peeling. It is possible to peel membranes under silicone oil. In this picture, the secondary macular membrane was peeled with vitreous forceps under silicone oil without first removing it after connecting the infusion port to air infusion. C3F8 and silicone oil have both been found to be equally effective for the tamponade of retinal detachments with PVR. The advantages of perfluoropropane are it absorbs spontaneously, giving temporary tamponade to the retina. It can control the duration of tamponade from intermediate to long duration by adjusting concentration of C3F8 with air. And visual rehabilitation occurs more rapidly in eyes with PVR treated with gas. There are relatively few long-term complications associated with use. The disadvantages are it does not last long enough to provide tamponade needed for eyes with epiretinal reproliferation, that is 6 to 8 weeks after surgery. And air travel is prohibited until the bubble is absorbed. And cataract formation is common if prone positioning is not maintained. There are some short-term complications such as elevated intraocular pressure and hypotony, which are more likely post-operatively. The advantages of silicone oil are it provides extended tamponade for months or years, allowing surgeon to determine if and when to remove the oil. The best tamponade for eyes with numerous retinal tears or large vitrectomies. It is better in achieving partial retinal reattachment in eyes with residual traction or reproliferation, and there are no restrictions on air travel. It is also a better tamponade for eyes with hypotony. The disadvantages are it does not prevent reproliferation in the inferior retina. Visual acuity is also slow to improve and causes substantial changes in refraction. It can also cause corneal toxicity, and cataract formation can occur in phakic eyes. Silicone oil is also prone to emulsification, and it can cause elevated intraocular pressure, and it has to be removed by a second surgical procedure. For post-operative management, patients should assume a face-down position for at least the first 24 hours after gas or light silicone oil exchange to allow the pigment epithelium to pump out any remaining SRF and to facilitate initial adhesion at the sites of photocoagulation or cryotherapy. Some surgeons insist on prone positioning for a much longer duration, up to 7 to 10 days for inferior breaks. If heavy silicone oil is used, the patient lies supine for 1 to 2 days and is then mobilized. They are advised to avoid sleeping on the back for the light silicone oil, as this encourages the oil to move away from the retinal surface and possibly into the anterior chamber. Shallowing of the anterior chamber may also occur. A rise in IOP is quite frequent after a high encircling buccal and silicone oil or gas, and it is important that this is monitored regularly. Post-operatively, patients are treated with corticosteroid, mydriatic, and cycloplegic drops 4 times daily for 3 to 4 weeks. Intraoperative bleeding may occur during dissection of dense membranes. This is treated by raising the infusion pressure temporarily and by diathermy. The view may be obscured by corneal edema, pupillary constriction, or lens clouding, and the corneal epithelium may be scraped clear or the pupil redilated with 1 in 10,000 epinephrine in vitrectomy infusion. Iris hooks or sphincterectomy can be done for small pupils, and lens clouding may need cataract surgery or 20-gauge fragmentome lensectomy via the pars plana. If heavy liquid or silicone oil passes under the retina, a retinotomy and further release of retinal traction should be done. Choroidal hemorrhagic detachments may occur during placement of scleral sutures or prolonged hypotony. This is treated by the temporary insertion of heavy liquid in the vitreous followed by external drainage of blood through a radial sclerotomy. Elevated intraocular pressure is the most common early post-operative complication occurring in 10 to 15% of eyes. A rise to 25 mm of mercury is treated with anti-glaucoma drops and oral acetazolamide. If higher than this, it is often due to ankle closure with forward shift of the iris diaphragm or overfill of the eye with gas or oil. In aphakic eyes with silicone oil, the pressure rise may be due to an incomplete inferior iridotomy or blocking of it with the lens capsule. It should be treated by a partial removal of the gas or silicone oil. Gas overfill can be removed with 30-gauge range through the pars plana, removing 0.2 cc or more. Post-operative inflammation is common, and fibrin may occlude or coat the posterior surface of the intraocular lens. This may be treated with topical and systemic steroids. Tissue plasminogen activator injection may break down fibrin in the anterior chamber, but is usually not necessary. An incomplete fill of silicone oil associated with fluid inferiorly may require reoperation with top-up of oil and internal drainage of fluid. For persistent epithelial defects, extended patching with antibiotic ointments is recommended. Endophthalmitis is rare, and gas or oil use can be removed and antibiotics instilled into the vitreous, or high-dose systemic antibiotics can be used. Regrowth of surface retinal membranes lead to macular pucker, retinal detachment, and tractional retinal tears. The commonest situation is inferior recurrence of retinal detachment with or without a new or reopened retinal break. If the fluid extends towards the posterior pole, reoperation can be considered. If it is peripheral, it is sometimes advisable to ward off with laser or supplement it with heavy silicone oil. Macular pucker can be peeled under silicone oil without removing it. Hypotony can occur due to proliferation of membranes over the ciliary body. This is difficult to treat, and in selected cases, membranes may be peeled off the ciliary body surface, followed by tamponade with silicone oil. Heavy liquid that has passed through a retinal break under the macular or inferior retina can be removed with a 39-gauge flexible subretinal cannula. Heavy liquid can be left in the vitreous cavity if small in volume, but has to be removed from the anterior chamber. Emulsification of silicone oil is very common with lower viscosity 1000 centistokes oil, especially if it has been mixed with inflammatory proteins or blood. Emulsified silicone oil should be removed, particularly if it causes glaucoma. It can be replaced if tamponade is still needed. Pankeratopathy is seen particularly in young people with long-standing silicone oil. It can be temporarily removed by scraping the cornea and applying the chelating agent. Cataract is universal in phakic eyes following vitrectomy and prolonged silicone oil tamponade. Cataract surgery can be performed at the time of initial vitrectomy or at the time of silicone oil removal. Cystoid macular edema can occur with or without pre-retinal membranes. Treatment is with topical steroids and NSAIDs. Intravitreal triamcinolone injection, and in special cases, peeling of the ILM over the macula. Sympathetic ophthalmia is a rare complication after multiple surgeries. Systemic prednisolone and subtenolone injection of long-acting celestone or triamcinolone have been used to dampen down inflammation that leads to PVR. Triamcinolone can be used during surgery to delaminate fine tissue planes. It can also be injected into silicone oil for slow release. Anti-proliferative agents like 5-FU and donomycin have been evaluated and has not been sufficient to demonstrate a clinical benefit in humans. The cause and outcome of retinal detachment surgery for PVR has not been very good. Recent series reports final anatomic success rates of about 70%. Untreated PVR leads to severe loss of vision, hypotony, and sometimes phthisis bulbi. With modern techniques, including vitrectomy, anatomic success rate is being achieved in an increasing number of cases. With multiple operations, up to 91% of all PVR-affected retinas can be attached. In one case series, 74% of eyes ended up with 20/400 or better vision, with 30% having 20/80 or better vision. Despite improved anatomical outcomes, visual outcomes are often disappointing. Visual loss in PVR is a combination of photoreceptor degeneration and apoptosis, neural remodeling, and epi- and subretinal pathology. Subretinal gliosis prevents photoreceptor regeneration. 2/3 of PVR cases with poor visual recovery have cystoid macular edema, and treatment of this with topical steroids and anti-inflammatory medications or potentially intraocular steroid injections may be of value in improving visual outcomes. And with that, I come to the end of my talk. Thank you very much for your kind.
Thank you, Dr. Sheena, for enlightening us on the management of proliferative vitreoretinopathy. So we'll proceed to the next topic. Our next speaker is Dr. Chin Kelvin. Dr. Kelvin is currently a vitreoretina consultant in KPJ Sabah Specialist Hospital. He obtained his undergraduate degree from University of Alberta in 1999, and he did his master in ophthalmology in UKM in 2008. He then did his subspecialty training in vitreoretina under Hospitals Layang and also Westmead Hospital, Sydney. Dr. Kelvin used to work in ophthalmology department in Hospital Queen Elizabeth as an ophthalmologist and also a vitreoretina consultant. Dr. Kelvin will be talking about vitreoretina management in complicated cataract surgery. Cataract surgeries are bread and butter for each ophthalmologist. However, not every single cases will be as smooth as butter. Hence, Dr. Kelvin will be enlightening us on how to deal with complicated cataract surgery together with vitreoretina management. Let's welcome Dr. Kelvin.
Hello, good morning everyone. My name is Kelvin. I'm a consultant ophthalmologist and VR surgeon at the KPJ Sabah Specialist Hospital. First of all, I'd like to thank the organizing committee for inviting me to speak at this Borneo Ophthalmology Update 2022. The topic of my presentation is VR management in complicated cataract surgery. So this is a video of me doing a phaco emulsification sometime last year. I was at this stage of the surgery, I was having difficulty in rotating the nucleus. It doesn't seem to be going very well, so I thought perhaps I should just try to do some more hydrodissection. I was trying to rotate the nucleus, but it just doesn't seem to be bulging. So I decided to remove the second instrument, and as the moment I did that, you can see that the nucleus started tilting downwards, and it's starting to fall, and it's falling, and it's falling, and now it's gone. All right. So, ladies and gentlemen, that is a drop nucleus. The drop nucleus is one of the most feared complications of modern cataract surgery. This involves the dislocation of the entire nucleus or part of the nuclear fragment into the vitreous cavity during the surgery. So this complication was previously rarely seen prior to the advent of phacoemulsification, because previously the entire lens was expressed through a large corneal wound. A drop nucleus can occur in two ways. Firstly, it can occur because of weak zonules, resulting in an anterior to posterior pressure gradient, pushing the nucleus posteriorly, or it can happen because of a posterior capsular rent. Data from published studies actually reassures that the incidence of drop nucleus is actually quite low. The incidence can range between 0.3 to 1.1%. There was one study that was conducted in 2007 at University of Malaya, and the incidence at that time was 1.84%. I believe this number should be lower now with the newer phaco machines and better phaco training. Now, the predisposing factors would include a hard cataract, polar cataracts, previously vitrectomized eyes, previous intravitreal injections, and high myopia. So what are the signs of a drop nucleus? Well, it's usually sudden in onset, but it may be preceded by signs of a PCR zonulitis. These include a sudden deepening of the anterior chamber, difficulty in rotating nucleus as illustrated in my video, decreased fallibility, a pupillary snap sign, and a nuclear tilt. So I'm sure you know all these signs of a PCR, but perhaps something that no one has ever told you is the biggest sign of an impending PCR is denial. Okay, so you get this feeling that everything is fine, everything's okay. Well, if you ever get this feeling of denial when you're doing a cataract surgery, be wary, be careful, because what you may be looking at is an impending drop nucleus. So the nucleus has dropped. What now? The first thing to do is to remain calm. Well, I mean, I know that it's easier said rather than done, but look, it's not the end of the world. Now remember, do not attempt to continue phaco, okay? Because vitreous cannot be emulsified. So never chase the cataract, because once you start chasing the cataract, you're actually causing vitreous traction, which will probably lead to retinal breaks and retinal detachments. So what should you do next? Okay, I listed it down as two things: must-dos and optionals. So the must-dos first is to close up, okay, suture the main wound, okay, and give intracameral antibiotics, whether it's it doesn't matter whether it's cefuroxime or moxifloxacin. Now the optional things to do is to do a bimanual anterior vitrectomy, and if you're comfortable, to implant IOL in the sulcus if the CCC or the zonules are intact. Do not implant ACIOL. Okay, I can tell you all VR surgeons dislike ACIOL in the eye. Some of you may be wondering, is there any difference between doing a coaxial anterior vitrectomy as compared to doing a bimanual? Well, actually yes. If you look at this video, you can actually see the first video is the coaxial anterior vitrectomy. As the cutter goes into the anterior chamber, you can actually see a lot of fluid leaking through the main wound. So when this fluid leak from the wound, vitreous will also prolapse through that wound. So that's not a very good idea, because the vitreous will keep prolapsing through the wound. If you look at the other side, the other video, this is a video of a bimanual anterior vitrectomy. Now, bimanual vitrectomy is preferred as it has advantages of 360-degree access between opposite ports and the ability to direct irrigating fluid away from the rent and fragment, thus preventing vitreous hydration and decreasing vitreous prolapse and fragment drop into the vitreous cavity. You also notice that there is no leak from the main wound. So you finish the surgery, what's next? The first thing you do is to explain to the patient that a complication has occurred, that the patient will need to undergo a second surgery to fix the complication. You need to start the patient on, firstly, intensive topical antibiotics and steroids, oral antibiotics, preferably ciprofloxacin, and if there are no contraindications, oral steroids. The next thing to do is to refer to a vitreoretinal surgeon to plan for a pars-plana vitrectomy and removal of the drop nucleus. So the timing of the surgery really depends on a few things. Firstly, logistics. How soon can the patient get to the VR surgeon? Second thing is corneal clarity. The best VR surgeon won't be able to do anything if the cornea is hazy. So we may have to delay the surgery to wait for the cornea to clear up. And then last but not the least, the patient's medical condition. If the patient is unfit, we need to make sure that we optimize the patient's medical condition before the patient goes for vitrectomy surgery. So let me now present my case. This is a 58-year-old gentleman who had a history of diabetes mellitus and diabetic maculopathy. He had previously undergone multiple intravitreal anti-VEGF injections, and the referring surgeon noted the lens suddenly dropped after sculpting and cracking the nucleus. In the interest of time, the video speed will be increased. This is my VR setup. I'm using a Borneo Solaris PC with a 25 gauge vitrectomy pack. 3 pars plana ports have been placed 3.5 mm behind the limbus. The infusion line is going through the top right port. The vitrectomy cutter is going through the lower right port, and the illumination light pipe is going through the bottom left port. In the beginning, what I do is I clear out the vitreous in the anterior part, the vitreous cavity, and once the vitreous has been cleared, I would switch off the cutter and just use aspiration and to remove the cortical matter. So this is pretty much like doing a INA after your phaco emulsification. So I will engage the cortex and just slowly tease it out. I would be careful not to pull on any vitreous. If I see any vitreous, I will turn the cutter back on and make sure I cut it before I remove it. So I'm now switching to my left hand and I'm clearing the remaining cortical matter in the eye. So after that's done, I'm going to the vitreous cavity, and this is the part when I need to remove the bulk of the vitreous in the vitreous cavity. So in this part of the video, I am now clearing the vitreous in the peripheral part of the cavity. The cornea is a little bit dry, so what I do is I just irrigate the cornea and just place HPMC gel to keep the cornea moist. I inject triamcinolone acetonide to make the vitreous more visible. So it is imperative for us to clear out all the vitreous to prevent any traction on the retina. Here I am trying to cut the nucleus using the cutter. Now, unfortunately, this nucleus is just a bit too tough. So with the softer nucleus, I can actually get away just removing the nucleus using the cutter. But unfortunately, in this case, it's a bit too hard, and then I'll need to bring in the fragmentome later on. So here I am just cleaning up the remnant, clearing up the remnant vitreous. So once I'm done with removing all the vitreous, I would then do a paratomy. There we are, paratomy is done, hemostasis is secured, and then I'm making a sclerostomy 3.5 mm behind the limbus. I'm using a 19 gauge MVR blade. And then I'm bringing out the big gun. This is the fragmentome. The fragmentome is essentially an elongated phaco tip, which doesn't come with a sleeve. Okay, so there goes the fragmentome. So with the fragmentome, I would engage the nucleus and then use the light pipe as a second instrument to manipulate the nucleus. I would do the emulsification at the mid-vitreous position, because I want to stay away from the retina, because I do not want to accidentally hit the retina and cause any retinal damage. So this is something that you need to do. Just pick it up and then emulsify it. The typical vacuum that we use in this setting is about 120 to 160 millimeters of mercury. So that's way less than the 300 to 400 that you use in your typical phaco emulsification. So here I'm just clearing up the final bits of the nucleus in the eye. And once that's done, next thing is to actually close the sclerostomy with a AO Vicreous. And once that's done, it's time to put in the lens. Unfortunately, the cornea has become pretty cloudy by the time I need to implant the lens. So what I did was to decided to do was to extend the wound and to actually load the lens manually. Here I am putting in viscoelastic, and then now I'm preparing the lens. I'm using a 3-piece IOL to be placed in the sulcus. So this is an Alcon MN60AC lens. So I place the lens, as I always do, in the usual fashion. I'm dialing in the trailing haptic with a dialer, positioning the lens. So next thing I'll do is I'll use just BSS to flush out the remnant of the viscoelastic. And by just turning on the infusion, you can see the viscoelastic burping out. Once the viscoelastic is out of the eye, the next thing to do is to use a 10-0 nylon to close the corneal wound. So once that's done, I would remove the ports, and then if needed, I'll suture the ports with the AO Vicreous as well. So this is what happens when the phacosurgeon doesn't respect the vitreous. In addition to the drop nucleus, you can see that in this video, the retina is detached. So at this point during the surgery, I've already removed all the vitreous, and I'm now using the fragmentome to emulsify the nucleus. I'm trying to do it in the center of the vitreous cavity, and I'm using low vacuum to try to reduce the risk of the retina being sucked into the fragmentome. So I'm just doing that very carefully, but despite that, you can see the retina coming towards the fragmentome, as in here. Okay, so after I finish removing this nucleus, I would then have to proceed to do a retinal detachment surgery to reattach the retina and put in the tamponade to support the retina. So as much as you can, try not to create a difficult situation like this for the VR surgeon. So this brings me to the conclusion of my presentation, the take-home message. As terrible as it seems, a drop nucleus is not the end of the world. In fact, most patients do quite well after vitrectomy surgery and the removal of the drop nucleus. Just remember, there's no shame to convert when things are going wrong. Okay, no one's going to say or blame you for converting, right? But if the lens has really dropped, the first thing to do is to remain calm, okay? And remember, always stop doing the phaco. Just stop doing any phaco, all right? And then the last thing to do is to close up and suture the wound, okay? So I hope that helps, and thanks very much for your kind attention.
Thank you very much to Dr. Kelvin for your presentations. We would like to welcome the next speaker and the last speaker of this session. The next speaker is Dr. Jen Fumeli. Dr. Jen is currently the Vitreous Retina consultant in Ipoh Eye Specialist Center. Dr. Jen graduated from University Putra, Malaysia, and did her postgrad training in National University of Malaysia. She then completed her Vitreous Retina training in Hospitals Layang and Westmead Hospital, Sydney, Australia. Dr. Jen used to serve in Hospital Queen Elizabeth as house officer and also medical officer in ophthalmology department. Dr. Jen will be talking on endophthalmitis to us today. Endophthalmitis can be a nightmare to any ophthalmologist. However, with proper and timely intervention, the likelihood of regaining vision can be promising. In this presentation, Dr. Jen will be speaking on when to intervene and when dealing with the cases of endophthalmitis. Let's welcome Dr. Jen.
Good afternoon to everyone. First and foremost, I would like to thank the organizers for the invitation to give this talk. The topic of my talk is endophthalmitis, when to intervene. I have no financial disclosures. Should be treated as an ophthalmic emergency due to its potentially blinding outcome. Diagnosis should be prompt, as the most important aspect of management is early recognition and early initiation of therapy, which include intravitreal antibiotics and pars-plana vitrectomy. It is classified based on timing of onset after surgery, causative microorganisms, and mode of entry of pathogens into the eye, whether it's exogenous or endogenous. In this talk, we will focus on exogenous endophthalmitis, of which the commonest cause is post-operative. Post-operative endophthalmitis or POE incidence is about 1 in 1,000 surgeries. The commonest cause is cataract surgery, as is the most widely performed surgery worldwide. Currently, worldwide incidence is around 0.02 to 1%. In recent years, endophthalmitis post-intravitreal injection has seen an increasing trend since the introduction of anti-VEGF agents. Fortunately, the relative incidence is still low. This graph shows the incidence of endophthalmitis in the Ministry of Health from 2008 to 2018, demonstrating a decreasing trend. The yearly incidence has maintained the national key performance indicator of less than 0.2% per year. This table shows the incidence in other surgical procedures, most common after secondary intraocular lens implantation and least common in pars-plana vitrectomy. It can also occur rarely in extraocular procedures like removal of corneal sutures. In cataract surgery, intracapsular cataract extraction has the highest risk due to large wound and performance of anterior vitrectomy. Surgeries complicated with posterior capsule rupture may allow entry of microorganisms with a breach in posterior capsule. Polypropylene and silicone IOL material is prone to higher bacterial adhesion. In trabeculectomy and shunt surgeries, risks of endophthalmitis include leaking bleb and antimetabolite use, which can cause corneal and scleral melt. In penetrating keratoplasty, risks include contaminated donor button and leaking wound. Coagulase negative staphylococcus, which is part of the ocular flora, is the commonest cause in acute cases, while Propionibacterium acnes is associated with chronic endophthalmitis post-cataract surgery. In chronic post-glaucoma surgery endophthalmitis, It is associated with more virulent bacteria like Streptococcus. As mentioned previously, the commonest source of organism is from the patient's ocular flora. This table shows various risk factors pre-operatively, intraoperatively, and after surgery, which are related to the ocular surface and surrounding areas. Other than immunosuppression and systemic infections, respiratory and skin flora of surgeon and assistants were also documented risk factors. Prompt diagnosis of endophthalmitis is crucial for early management. A low threshold of suspicion if inflammation is more severe than usual after surgery, and then to look for the source, for example wound leak and suture abscess. The commonest complaints are blurring of vision and eye redness. Clinically, hypoprion and vitritis are red flag signs for the diagnosis. Other signs include corneal edema and erythematous leads. These pictures show the various clinical presentations. From the top left, vitreous weak syndrome, retinal periphlebitis, and corneal infiltrates at the incision site. In chronic endophthalmitis, there are similar signs with acute presentation. More likely seen in chronic endophthalmitis are plaques on IOL, strings or pearls infiltrate if seen is likely caused by fungal infection, persistent low-grade uveitis which may initially respond to topical steroid. In examination of patients with endophthalmitis, visual acuity or light perception need to be differentiated from hand movement, which is important for management options and prognosis. Due to usually poor fundus view, B-scan is an important tool to look for vitreous loculations, which is diagnostic, scleral thickening for panophthalmitis, and to rule out concurrent retinal or choroidal detachments, lens material in the vitreous, and retained intraocular foreign body. Subsequently is to consider other differential diagnosis of post-cataract surgical inflammation. In acute presentation, the differential diagnoses are toxic anterior segment syndrome or TAS, lens-induced uveitis, and reactivation of uveitis. The next two slides will briefly explain about TAS. Toxic anterior segment syndrome, which is a steroid inflammation, usually starts within 1 day after cataract surgery, which is limited to the anterior chamber. It is very responsive to steroids, and the cultures are negative. This table shows further comparison of TAS with endophthalmitis. In TAS, the corneal edema extends from limbus to limbus. Eye pain is usually not severe, and there is usually no lid swelling. The differential diagnosis for chronic endophthalmitis are as the following. From the top picture, it shows inflammation due to retained lens matter, uveitis with subluxated IOL in UGH syndrome, and vitritis in primary intraocular lymphoma. After a diagnosis of endophthalmitis is made, management of endophthalmitis will be discussed under the following: vitreous tab with or without aqueous tab, intravitreal antibiotics, topical and systemic antibiotics, steroids, and pars plana vitrectomy. According to the Malaysian Clinical Practice Guidelines for Endophthalmitis, vitreous tab and intravitreal antibiotics should be given within 1 hour of diagnosis. Additional aqueous tab is helpful, though the yield of positive cultures are less than the vitreous sample. PCR is helpful in chronic endophthalmitis with low pathogen counts. Vitreous biopsy has not been found to be superior to vitreous tab. Conjunctival and corneal swabs are usually not helpful. Intravitreal antibiotics of choice need to have a broad coverage of organism. Vancomycin covers for gram-positive cocci, while ceftazidime covers for gram-negative bacilli. Ceftazidime is preferred from amikacin due to reports of macular infarction after amikacin. If fungal infection is suspected, intravitreal amphotericin B is given. This is the algorithm for acute endophthalmitis management from the CPG. After clinical diagnosis and vitreous tab and inject done, Intensive topical antibiotics and topical steroids are started. Then consider to repeat intravitreal antibiotics after 48 to 72 hours if needed, or an early referral to the vitreoretinal unit. This is the algorithm for management of chronic post-operative endophthalmitis. The additional steps compared to management for acute endophthalmitis include IOL explantation consideration, intravitreal antifungal, and intracameral recombinant tissue plasminogen activator. After intravitreal antibiotic injections, broad-spectrum topical antibiotics is instilled frequently every hour, and then adjusted according to the response. Subconjunctival midocaine is given for extensive posterior synechia with small pupil. Topical antibiotics are beneficial as an adjunct, especially for concurrent anterior segment pathology. Systemic antibiotics are given for severe and virulent cases. However, systemic antibiotics, that is IV ceftazidime and IV amikacin, have not been found to improve visual outcome in the EVS study. Other alternatives are moxifloxacin and ciprofloxacin for 10 and 14 days respectively. Oral moxifloxacin and gefloxacin has been reported to be effective against many pathogens. It is promising as an adjunct to intravitreal antibiotics. For fungal infections, these are the antifungals of choice. Topical steroids is recommended to be given intensively after intravitreal antibiotics injection. Oral prednisolone is not given routinely as the evidence for its benefit is limited and is contraindicated in fungal endophthalmitis. Intravitreal dexamethasone benefit has been conflicting in various reports. In addition to subconjunctival midocaine, intracameral tissue plasminogen activator can be given if there is severe fibrinous reaction in the anterior chamber. Since the introduction of pars plana vitrectomy in the 1970s, technology advancement has increasingly made smaller gauge incisions and higher cutting rates, thus increasing the safety of the surgery. In endophthalmitis cases, there are several theoretical advantages, namely removal of the infective bulk, removal of fractional membranes, clearing of media, collection of vitreous for culture, and possibly help distribution of intravitreal antibiotics given at the end of surgery. Here I would like to highlight two studies regarding vitrectomy for cases of endophthalmitis. The first is endophthalmitis vitrectomy study or EVS, and the second is complete and early vitrectomy for endophthalmitis after cataract surgery or CEVE. Endophthalmitis vitrectomy study or EVS was a multi-center trial in early 1990s which included patients with acute endophthalmitis presenting with vision of light perception or better. Treatment was initiated within 6 hours and randomized to 4 groups, looking at initial vitrectomy or TAP and with or without intravenous antibiotics. All patients were given intravitreal vancomycin and amikacin with topical and systemic steroids. All eyes had an anterior chamber sample taken. In vitrectomy, an initial undiluted vitreous sample was taken before turning on the infusion. Then the vitrectomy was continued. If there was no posterior vitreous detachment, there was no attempt to induce the PVD. Therefore, the posterior cortical vitreous was not aggressively removed. The goal of surgery was to remove at least 50% of the vitreous gel. Results of the EVS showed that there was no difference in final visual acuity or media clarity whether or not systemic antibiotics were given. For patients with hand movement or better vision, there was no difference in the visual outcome between both arms. But for patients with initial visual acuity or light perception only, better visual results were seen in immediate vitrectomy group, where they were 3 times more likely to achieve vision of better than 6/12. In the complete and early vitrectomy for endophthalmitis or CEVE study, the rationale of the study was, since the EVS era, vitrectomy has become safer and more efficient. However, visual outcome after endophthalmitis still remain poor due to maculopathy as noted in EVS. So therefore, This study aimed to improve the outcome by removing purulence from macula by performing a complete vitrectomy and reducing retinal damage from toxins from early vitrectomy. The study included 62 eyes from 2007 to 2017. It included patients presenting with acute endophthalmitis 3 weeks after cataract surgery. Vitrectomy was performed for all cases except early endophthalmitis. If there was no PVD, an induction of PVD was made. All patients received intravitreal antibiotics and retreatment was considered if there was worsening medial opacity. The results showed that majority underwent vitrectomy and 61% received retreatment. In comparison to AVS, CEVE had more patients receiving more than one treatment, more patients achieving good visual outcome, 6/12 or better, and less rate of retinal detachment post-operatively. Since the EVS was published, there is still no consensus on the guidelines of management. The following slides show retrospective reviews of the authors on their practice patterns. This was a review of 164 cases in Korea from 2008 to 2015. Primary vitrectomy was performed in 68.3% compared to intravitreal antibiotics alone. Final visual acuity was comparable to the EVS, but there was no significant difference within both vitrectomy and injection groups. However, there was less retreatment needed in the primary vitrectomy group. This was a study done in the UK on 33 eyes from 2013 to 2018. The results showed that vitrectomy improved vision in 1/3 of cases. Early vitrectomy within 7 days improved the final visual acuity as delayed treatment had poorer outcome from retinal ischemia and retinal fibrosis. This was a multi-center study done by the European Vitreoretinal Society from 2016 to 2017 on the practice patterns for the management of acute post-surgical and post-intravitreal injection endophthalmitis. There were 237 eyes. The aim was to analyze the rate of vitrectomy, intravitreal steroids, and repeat intravitreal antibiotic. The results showed early vitrectomy was performed in 74.3%, while intravitreal steroids and re-injection was performed in 1/4 of cases. Prevention is always better than cure. Therefore, it's important to identify and treat the risk factors, employ aseptic technique throughout surgery, proper wound creation, and routine use of antibiotics. Risk factors are treated accordingly, and surgery may need to be rescheduled after optimization. Sterile technique of ocular field include hand washing and sterile gloves. Preparation of surgical site with 10% povidone iodine on the skin and 5% in the conjunctival sac. Povidone iodine has a broad antimicrobial spectrum and provide powerful antimicrobial effect after 1 minute of skin contact. Proper draping technique with adhesive drape and speculum ensures isolation of lashes from the ocular area. This can be aided by additional tapes on the lashes and lid margins. Regarding location of the wound, the temporal wound has a relative risk of 4.6 compared to a superior wound, and a corneoscleral wound has a 65% relative risk reduction compared to a clear corneal incision, as the wound healing is shorter in a limbal-based wound. Regarding wound construction, a small square-shaped wound has less risk, and also by avoiding a decimate tear at the incision site. A good wound seal is important by performing stromal hydration at all incision sites, which is present for at least 24 hours after surgery. Regarding antibiotic prophylaxis, the CPG has recommended intracameral cefuroxime 1 mg per 0.1 ml at the end of surgery. Vancomycin in irrigating solution and pre-operative antibiotics have not been found to be beneficial. In the ESCRS study, intracameral cefuroxime have been found to reduce the rate of endophthalmitis by 5-fold compared to topical levofloxacin only. At that time in the United States, Intracameral caffeoxime was not approved by FDA. Therefore, topical fluoroquinolones were used and was found to be effective. The reason against this was since intracameral caffeoxime was not available as single unit dose, there was risk of dilution error and contamination. There was also no MRSA and Pseudomonas coverage and risk of allergy to cephalosporin. Currently, it is already available in commercial form called Aprocam. Therefore, it is increasingly used as off-label in the United States. Intracameral moxifloxacin, which is a fourth-generation fluoroquinolone, is increasingly used worldwide. It has a broader spectrum compared to caffeoxime, which include MRSA and gram-negative organisms. It has been shown to be effective to reduce endophthalmitis from 0.38 to 0.05% and is also less toxic compared to caffeoxime or vancomycin. Intravitreal vancomycin has been abandoned due to reports of hemorrhagic occlusive retinal vasculitis, where in one study, 1/5 of patients became blind. In summary, endophthalmitis is an unwanted complication due to its guarded outcome. The risk of permanent visual loss doubles when vision drops to light perception. Therefore, prevention and early treatment is the key to fight this enemy. With that, I conclude my talk. Thank you for listening.
Thank you very much, Dr. Jen. So we come to our Q&A session, and we have a few questions for the panelists. So we would like to invite our speakers, Dr. Peter, Dr. Sheena, Dr. Kevin, and Dr. Jen to join our Q&A session. We were informed by Dr. Jen that maybe she might not be free because she's busy in operation theater. Maybe we'll start our session first. Okay. First questions is for Dr. Peter. In terms of macular hole surgery between brilliant blue and dual membrane blue, which one is better in your experience, Dr. Kong?
I prefer to use brilliant peel because it's heavy, it stain the IRM better. ERM is stained better by the twin dye because the tryptophan component will stain the ERM clearer. But after you peel the ERM, the IRM normally is quite faint. So you need to re-stain again with the twin dye to enhance the staining. But anyhow, technically ERM is simpler to peel. So even a bit of dyeing of the membrane will allow a proper peeling of the ERM. Because IRM is technically more challenging. Therefore, I still prefer the superior staining of the brilliant peel for that reason.
Okay, Dr. Kong. How about Dr. Sheena? What do you think?
I use membrane peel as well. I think I prefer that light stains better, I think, for surgery. So that's just from my experience.
I see. Okay, thank you, Dr. Sheena. Next questions is to Dr. Kong as well. In a case of full thickness macular hole, who has been there for 2 to 3 years, will you still proceed with macular hole surgery? And what are the criteria that you will look at when you dealing with this kind of chronic macular hole?
So the important factor is actually about the ability for the hole to close and how much closure will lead to proper anatomical restoration. Yeah, so you look at the prosthetic factor depending on the clinical changes like pigmentary changes and chronicity, as well as a feature on the OCT. Now, after that, you have to discuss with the patient about the potential outcome. You have to discuss frankly regarding the prognosis. In this case, normally guarded and probably may improve in 1 or 2 lines, or something we are lucky, maybe more than that. Now I have, the longest I have ever done is a hole which was 10 years, you know, in duration, because the patient had macular hole in one eye. He didn't want the operation until macular hole developed in the other eye. 10 years later, after the second eye operation, she opted to do the first eye again, and that hole was closed and the vision was improved from counting finger to 660. So sometimes you do get surprises. Yeah. So I would discuss with the patient and offer the option. Yeah. But basically, all this method I use IRM flap and the hole close. Yeah, I didn't use the other more fancy method by other author. I just use IRM flap and the hole close.
Okay, Dr. Kong. How about Dr. Kelvin? Will you proceed with surgery in chronic macular hole patient?
Yeah, hi. I would actually need to discuss the patient and explain to them that the success rate of chronic hole closure is much less, and I'll discuss option. If the patient's keen, of course, I'll go ahead and do the surgery.
I see. Okay, thank you, Dr. Kelvin. The next question is for Dr. Sheena. Dr. Sheena, what is your opinion on the usage of intravitreal methotrexate in the treatments of PVR?
Well, there have been reports that intravitreal methotrexate is effective for the prevention of recurrent RD after treatment. Currently, there's a randomized controlled trial being done on intravitreal methotrexate injection. But the drawback is the injection has to be given 13 times. In the first 8 weeks, it's weekly, and in the second 8 weeks, it's every other week. So we'll wait for the results of the study, but it looks promising at this moment.
Dr. Kong, do you have any experience of using methotrexate in the management of PVR?
No, I haven't used methotrexate, but I did use one case of mitomycin C intraoperatively for PVR. Yeah,
I see.
And that case turned out to be quite all right. And I only used it especially for that case because it was chronic and quite bad PVR. There have been many reports using mitomycin C as an intraoperative antimetabolites for cases with severe PVR from a traumatic case. I think in those kind of cases where the PVR rate is so high that this antimetabolite should be used as an adjuvant.
Okay, Dr.
For high risk case. Yeah.
I see. Okay. The next question is also for Dr. Sheena. How long will RRD? How long after the RRD develop? How long after RRD develop will have a PVR usually?
Oh, okay. PVR after just a retinal detachment can develop early. Within 2 weeks, I would say it can start developing. But if it's after retinal detachment surgery, because PVR can occur after retinal detachment surgery, that takes about 4 to 6 weeks for the whole process to start up.
Okay. How about the surgery for PVR? When is the perfluorocarbon liquid indicated? And how long can we leave the perfluorocarbon liquid in the eye before it causes any toxicity?
Well, usually I use perfluorocarbons for complicated surgeries, like when they need a retinectomy to stabilize the retina, or for giant retinal tears, also to unfold the retina. Or also if you are peeling some membranes on the surface of the retina and you need counter traction, heavy liquid is a good substance to use. And also during removal of foreign bodies or intraocular lenses, you can protect the macular area by putting heavy liquids in the posterior pole. Or also you can float up foreign bodies or intraocular lenses using heavy liquids if you want to remove it from the anterior segment as well. So, and usually I wouldn't recommend leaving it in the eye unless it's really necessary. But the maximum I would leave it in the eye in severe retinal detachments with severe PVR would be about 1 week.
Retina. Okay, we proceed to the next questions. Next question, I think, is for Dr. Kevin. Dr. Kevin, do you operate on all the drop nucleus patients, or you any situation that you will choose to observe without doing any surgical interventions in a drop nucleus case?
Well, I mean, it really depends on how large the drop nucleus is and whether it's the part of the nucleus or just some cortical matter. I would say that if the lens matter is small and it's not causing too much of a reaction, and patients responding well to the oral steroids and the topical drops, then we can always watch it. There's no hurry to actually go in to do the operation. So if it doesn't clear up, you can always do the operation later.
I see. How about Dr. Kong? What's your preference in these kind of cases?
Yeah, I totally agree with Dr. Kelvin. Yeah, small cortical matter, it's best to leave alone. Don't forget, every surgery carry a risk. Yeah.
Okay. Next question is also for Dr. Kelvin. Would the VR surgeon prefer an IOL to be implanted after a nucleus drop, or is it best to leave it at phakic?
Okay, I think that really depends on who you ask, okay? But generally, we would prefer if the operating surgeon does not mess up the eye more, okay? So basically, if you're comfortable putting in the lens, then go ahead, put in the lens. But do put in a 3-piece lens into the sulcus, okay? If you have to put in an AC lens, then I would rather you not put in, okay? And I'll put it in myself, all right? So I think as a general rule, it is okay to leave the eye vacate, not to put in the lens, but try to just clear up as much of the lens matter as you can. All right. So it's not mandatory to put in intraocular lens. We can do it during the surgery. Okay.
Okay, Doctor. How about you, Dr. Sheena? What is your?
Usually I tell people if you can put in a sulcus lens without problems, then put in a sulcus lens. But I always tell people don't put in an ACIOL because that will make our view more difficult when we are trying to do the vitrectomy later.
Okay. The next question is also for Dr. Kevin. Do we need to give systemic antibiotic in the case of drop nucleus? Dr. Kevin is busy. Maybe Dr. Kong, can you answer the questions for us?
Yeah, most likely I would prefer, because there's a increased risk of infection after a complicated surgery. Yeah, so it's better to cover with antibiotics till the time of surgery.
Okay. How about Dr. Sheena?
Sorry, what was the question?
Do we need to give systemic antibiotics for patients with nucleus drop?
Usually I don't give if there's no signs of infection. Usually I don't give unless there's a lot of fibrin or any sign of inflammation. Then I would, yeah.
Dr. Kevin, would you give systemic antibiotic?
Well, look, I'm not sure whether it really works or not, but I do give, probably to make myself feel better, okay? But I will give ciprofloxacin 500 mg PD for a week. Yes.
Okay, Dr. Kevin. Another question, in the case of drop cortical matter, how long would you wait and how long you will give the oral steroid?
I will give the steroid for a week or two, and usually I'll wait for up to a month to see whether the cortical matter reabsorbs.
So along the way, you will taper the steroid, or will you just keep the same dosage?
Usually I just keep the dosage, 0.5 milligram per day.
Okay, Dr. Kevin. All right. So there are quite a number of questions for endophthalmitis. Is Dr. Jen free for the Q&A session? I think probably Dr. Jen is busy. Maybe we can have invite other speakers to answer for Dr. Jen. The first question is, how many times of intravitreal vancomycin and Fortum do we give to patients with endoph before we consider to proceed with vitrectomy? Maybe Dr. Sheena?
For me, I only usually give once, and then we proceed with vitrectomy if the cornea is clear. But if the cornea is hazy and we can't proceed for vitrectomy, then I might give up to 2 or 3 times while we are waiting for the cornea to clear.
How about Dr. Peter?
Yeah, I agree. Yeah, the aim is to try to do as early vitrectomy as possible. One is permissible. So as soon as you give the antibiotic, as soon as the vitreous is clear, you want to go in and clear the vitreous.
Okay, Doctor. So next question is, when do you consider to add in intravitreal dexamethasone together with intravitreal antibiotic in the case of endophthalmitis? Maybe Dr. Kevin?
Definitely, you don't want to give dexamethasone as the first injection. So this will be given usually as for me, I'll usually give as a third injection. So I'm given 2. So I'll give 1, and then after 2 or 3 days, if the patient's responding, I give another 1. And if I need to give the third one, then I will give the dexamethasone, just to make sure that everything is actually getting better before you give the intravitreal dexamethasone.
Dr. Sheena?
Basically, yeah, I would not give it definitely as the first or second injection, but maybe as the third or later. But I rarely use dexamethasone.
Okay. Next questions. In the case of post-vitrectomized eyes with silicone oil field, is that common to have endophthalmitis? And how would it proceed in this kind of cases? Maybe Dr. Kong?
Very rare, because silicone oil itself usually is not a medium for the bacteria to grow, so not common. Yeah, but in this type of case, I will proceed with injection of the antibiotics. The oil itself can serve as a reservoir, and the antibiotics will probably stay longer inside the eye with a longer half-life with the oil inside. Yeah, but it's very rare with the oil inside.
Is it the same dosage of antibiotic? Do we need to change the dosage or anything?
I will give the same dosage, but I think it will last and will have a longer half-life. Yeah.
Okay. How about Dr. Kevin?
Sorry, I missed that. You were saying?
In the case of a post-vitrectomized eye with silicone oil, the possibility of getting endophthalmitis and treatment with antibiotic.
I think because the silicone oil is actually a good medium to prevent the proliferation of the bacteria. You don't get much. You usually don't get endophthalmitis after that. But if it does happen, you can always give intravitreal antibiotics as per usual.
Okay. All right. Next questions. In your practice for post-op endophthalmitis, what will be the cutoff point in terms of visual acuity to perform a vitrectomy? Dr. Sheena?
I don't have a cutoff point because I aim to do a vitrectomy in all patients as long as the cornea is clear enough.
Okay. How about Dr. Kong?
Yeah, I do subscribe to the same principle. Yeah.
Same for Dr. Kelvin?
Yeah, I totally agree. So once the cornea is clear, usually with 1 intravitreal on board, we'll go ahead and do the vitrectomy.
Okay. Another question asked by the participants. Do we often repeat vitreous tap in culture negative post-op endophthalmitis patient? Maybe Dr. Kevin?
Usually no, because you have already injected the first intravitreal antibiotics, and if you can't get a yield the first time around, then probably you're not going to get anything the second time around.
Dr. Sheena?
Actually, usually we don't, but I think in selected circumstances, we may, if the infection is getting worse or worsening, we may take a second tap when we inject again, when we inject intravitreal antibiotics again.
I see. Okay, there's another question for macular hole. The participant would like to know the experience of medical therapy of using ocriplasmins for macular holes patient. Dr. Kong, have any experience on that?
Sorry, I don't have that experience because it was so difficult to get the drug to, especially in Kota Kinabalu. So if you do it in KL, maybe you can get you have to fly the drug from Belgium at those days, and then the moment it arrives, you have to quickly deliver to the operating theater, and you have to inject within a certain time. So I didn't have that experience. But according to the previous ocriplasmin study, it works in stage 1 or early stage 2. It works in about up to, I think, 60-70% of the time. But the problem is that after the vitreous separation, patient have a lot of floaters, and some end up with other complications like lens dislocation, cataract, vitreous hemorrhage, which is to be negated by a good vitrectomy surgery. So, and because of the cost of the medicine, the difficulty in getting the drugs to the place, and the side effect of the medicine, and with the modernization of a good vitrectomy technique, and that plasminogen, that ocriplasmin have been superseded. Yeah, that's why it's out of favor now.
I see. Dr. Kelvin, do you have any experience on that?
Sorry, I don't have any experience in this.
See, okay. All right, we proceed to the next questions. I think it's for Dr. Kevin. Is the intracameral cephalosim recommended to use in complicated cataract surgery with PC-RAN in view of the possibility of retina toxicity?
Okay, yeah, so I knew that question was coming, but okay, whoever asked the question has a valid point. But look, when we inject intracameral cephalosim, during a routine cataract operation, some of this cephalosim would end up in the retina, right? Because it goes through the zonules and everything. So the risk of retinal toxicity is actually very low. Okay. Now, if you don't inject any sort of intracameral antibiotics after a complicated surgery, the risk of getting a post-op endophthalmitis is much, much higher. So you need to weigh the balance. There's of course pros and cons of doing everything, but I believe that if you give an intracameral, either cephalosim or Vigamox, it would help reduce the risk of post-op endophthalmitis after complicated cataract surgery.
Okay, thank you, Dr. Kevin. I think we have answered most of the questions from the participants. Anyone else who would like to put in any questions from the participants? If there are no questions, I would like to thank our panelists again, Dr. Peter, Dr. Sheena, Dr. Kevin, and also Dr. Jen for joining us today. Thank you very much, and hope to see you again. And I'll pass back the floor to MC. Thank you very much.
Thank you.
Thank you to all the speakers for the informative presentations, and to Dr. Yap for handling the Q&A sessions just now. We will now have our lunch breaks and Friday prayers, and we'll resume to Medical Retina Symposium at 2 p.m. You may leave the webinars for the break and join us back at 2 p.m. for the next session using the same link that has been provided to you through your respective emails. Assalamualaikum, and thank you very much, everyone. Enjoy your lunch breaks.